We are live, sir.
Great, thank you. So good evening, everyone. So Dr. Chandan Das, it's all yours.
Okay, thank you, Tarun. So good evening, ladies and gentlemen. A warm welcome to all of you. So after a very good comprehensive discussion on ovarian cancer yesterday, so today we'll discuss about endometrial cancer, and hope the today's masterclass will answer some of your queries in your day-to-day practice. So this academic session will divide it into three parts. First part will focus on the diagnostic aspects. The second will have plenary sessions focused on the therapeutic aspect, and the last part will be a debate followed by a case discussion or panel discussions. So for the diagnostic aspects, we have three sessions in the radiology, pathology, and minimal invasive surgery. So I think Dr. Rakesh Kapoor could not join us for some other reasons. So I think we should start the sessions. So may I request Dr. Nilesh Sable, the Professor of Radiology in the TMH, to talk about the most important part in a C endometrium patient, which is pelvic MRI. Dr. Nilesh, please welcome. Please.
Thank you, Dr. Chandan. Should I share my screen?
Yes, please.
Yes. I want to thank the organizing team for giving me this opportunity. A very good evening to all of you. Good evening. I'm Dr. Nilesh Sable from Tata Memorial Hospital, Mumbai. I will be discussing in my talk about pelvic MRI in carcinoma endometrium. I will cover this topic in following heading. A brief discussion about the MR anatomy, MR techniques, stages of cancer as per imaging features, implication of management, and role of the MRI. So briefly, we'll discuss anatomy of uterus. Titulated images have excellent soft tissue resolution, and they have got excellent zonal differentiation also. The endometrium will be seen as a high signal intensity area in the center of uterus, which is usually less than 15 mm in thickness. It is surrounded by a junctional zone, which is a narrow zone of low signal intensity, which represents the inner myometrium, which is usually less than 11 mm, and the peripheral zone surrounds the uterus, the junctional zone of uterus, which represents the outer myometrium. The whole of the uterus is surrounded by very thin hypointense rim, which represents the cirrus of uterus. Now the anatomy of nodal region. There are three types of nodes in the pelvis. First category is common iliac nodes. Common iliac nodes can be divided further into the lateral, middle, and medial common iliac subgroups. External iliac nodes are also again subdivided into lateral, middle, and medial external iliac subgroups, which is also known as obturator group. Then the internal iliac nodes are subdivided into anterior, lateral sacral, presacral, and hypogastric nodes. The prognostic factors which affect the carcinoma endometrium are stage, depth of invasion, myometrial invasion, lymphovascular invasion, nodal status, and histological grade. Out of these, stage, depth of myometrial invasion, and nodal status can be commented upon on the imaging studies. So we have to first make the patient as well as the operator comfortable for the MRI before taking the patient for MRI. First, you have to empty the bladder, because it will the full bladder will cause a lot of artifacts in the MRI. as well as the patient will move if the bladder is full. The small FOV T2-weighted oblique sagittal and axial sequences are must. For nodal assessment, we use large FOV axial T2-weighted, T1 weighted and post-contrast T1 weighted sequences. For screening of upper abdomen, we use large FOV axial T2 weighted images, and we add diffusion weighted imaging and dynamic post-contrast imaging to the protocol. The staging, as all of you know, FIGO stage 1A is confined to uterus or tumors involving less than or equal to 50% of myometrial involvement, and then stage 1B, tumors involve more than 50% of myometrial involvement. Stage 2 tumors cause cervical stromal invasion, which will be seen as disruption of the stromal ring. The endocervical extension of the tumor without stromal invasion is regarded as stage 1 tumor. So this is an example of stage 1A tumor, where you can see a intermediate signal intensity mass in the endometrium. The junctional zone, as we have seen on the anatomy slide, is preserved. These are the DW diffusion weighted and ADC images and ADC map, which are showing restriction of the diffusion of this tumor. And this is the post-contrast image, where we can see the tumor is hypoenhancing, heterogeneously hypoenhancing compared to the adjacent myometrium. This is another case of stage 1A, where there is less than 50% of half of the myometrial invasion. This is one case where there is lateral myometrial invasion, and here there is an invasion of inner half of myometrium in the fundal region. Sorry for these images with artifacts. These are again images where you can see there is anteriorly there is involvement of the inner myometrium, and here the tumor is confined to the endometrium only. So this is a case where you can see there is involvement of the outer half of myometrium also posteriorly, reaching up to the subserosal region. But the serosa, you can see as a thin dark hypointense line, is not breached, and the tumor is not going outside the uterus. This is a case of stage 2 cervical stromal invasion, where you can see a intermediate signal intensity mass which is going down and involving the cervical stroma. In stage 3, the tumors are included, which involve cirrhosis of uterus or adnexa, which can be seen as irregular uterine contour or ovarian nodular contour. Stage 3B is involvement of upper vagina and parametrial fat. The stage 3C includes enlarged pelvic and parotid nodes, which are more than 8 mm or 10 mm in short axis in respective places. This is a post-contrast CT image of pelvis, where we can see the uterus is replaced by a heterogeneously enhancing soft tissue mass with nodular counter and the involvement of bilateral adnexal areas. Stage 4 includes the tumor involving the bladder and bowel mucosa. The bullous edema we should be identify and exclude from this region. Frank bladder invasion should be there to call it as 4A disease. And 4B includes metastasis to inguinal nodes, peritoneal implants, and other western metastasis like lung, liver, brain, skeletal, etc. So coming to nodal mapping, we have to see for the regional nodes, which are internal iliac, external iliac, common iliac, perivisceral, and paraortic. Inguinal nodes are usually regarded as non-regional nodes, and they are metastatic. We have to see for the short axis dimension, and if they are enlarged according to our previous slides, more than 8 mm and more than 10 mm in retroperitoneum, then we label these nodes as metastatic. The morphology also has to be seen, which should be heterogeneous signal intensity with heterogeneous enhancement and necrosis. Node positive endometrial cancer is more common in tumors with higher stage and grade. Pelvic nodal metastases are more common than parotid nodes. However, isolated parotid nodes can occur. This is a stage 3C CM endometrium CA, where we can see a heterogeneously enhancing left parotid node, and this is another case where we can see multiple parotid nodes with aortocaval node. So implication, stages 1A versus 1B has prognostic and morbidity implications. The depth of myometrial invasion is most important morphological prognostic marker, which correlates with the tumor grade, tumor extension into the cervix, and prevalence of the lymph node metastasis. Incidence of lymph node metastasis increases from 3% in superficial myometrial invasion, that is stage 1A, to 46% in the deep myometrial invasion, that is stage 1B. Gross cervical invasion requires preoperative radiation therapy or a different surgical plan like radical hysterectomy with pelvic and abdominal lymphadenopathy instead of total abdominal hysterectomy. Role: the staging accuracy of MRI is between 85 to 93%. The dynamic IV contrast imaging improves accuracy from 77 to 91%. The pitfalls in accuracy of myometrial invasion are large tumors which comprise the myometrium, corneal extension, coexisting abnormalities such as congenital anomalies and or adenomyosis, and poor tumor myometrial interface. So, role of MRI has been defined by following organizations: ACR appropriateness criteria, NCCN guidelines, ESUR guidelines, and 2015 multidisciplinary European expert consensus meeting, which recommend MRI for treatment and planning for of CA endometrium. So, let us discuss one case. A 61-year-old female presented to us with PV bleeding since 1 month, and ultrasound has been done outside. I don't have ultrasound images, and histology biopsy has been also done. And when the patient was referred to us, we have done MRI, and which show a heterogeneous intermediate signal intensity lesion in the endometrium, which is slightly involving the anterior junctional zone, you can see here, and on the lateral aspect also it's showing the junctional zone involvement. So these are the DW images and ADC maps which are showing restricted diffusion, and you can see in this image, this is zoom image of axial T2 Sag sequence, where you can see the small part of tumor is extending into the vagina, in the cervix. It's only endocervical lesion, so we can stage it as 1A. So incidentally, in the screening abdomen, we found this lesion in the left adrenal. We did a adrenal protocol MRI with adrenal protocol CT, and this lesion turned out to be an adenoma. So this is an histopathological report of this patient, clearly showing that less than half the thickness of myometrial invasion is there, and the cervix is not involved. So this becomes stage 1A, FIGO stage 1A. So to summarize, when findings of staging MRI and hysteroscopic biopsy are combined, women at high risk of lymph node metastasis can be identified preoperatively with accuracy of 81%. MRI is essentially needed in treatment planning of early stage endometrial cancers. However, higher stage tumors, CT scan can also be an option. Thank you.
Thank you, Dr. Nilesh. It's a really excellent presentation for the MRI for the CA endometrium. So one question from me. All of you can post your questions on Q&A section. So one question for Dr. Nilesh. Dr.
Yes.
Nilesh, the cervical assessment, cervical involvement, how adequately the MRI can predict? It is really, really great for the endometrial assessment, 50% or less than 50%. So my question is the cervical involvement, how adequately it actually predicts. So can you predict the microscopic versions, if at all?
No, microscopic cannot be predicted on MRI. Only gross cervical invasion can be predicted on MRI, as I have shown you in the in my slide.
Thank you, Dr. Nilesh. Yeah, this one.
This one. This is only the endocervical luminal growth, and the cervix, you can see it's continuing as the junctional zone, hypointense T2 rated image. So again, in the anatomy diagram, I can tell you this is sorry, not this. So this junction zone continues as cervical stroma downwards, and this outer myometrium also continues as cervical stroma, outer layer. So if these are disrupted, then we can definitely surely say that the cervical cervix is involved.
Thank you, Dr. Nilesh. This is indeed a learning for all of the oncologists, because these are the, if involved, then the treatment is entirely changes or do something else, right? Thank you, Dr. Nilesh, and thanks for the excellent presentation. I think the next session is by Dr. Mina Desai.
I have posted a question.
Oh, sure, please. So, Dr. Nilesh, the question is, at a stage 1A in MRI, what is the accuracy after surgery? Dr. Nilesh?
Yes.
So what is the accuracy after surgery if it's reported pre-operatively as a stage 1A?
It's around 83 to 93, 85 to 93%, as I've shown you here in my presentation in one of the slides. 85 to 93%.
Okay.
Okay, thank you.
Okay.
Thank you. So we'll move to the next session. It's by Dr. Mina Desai, the senior consultant histopathologist and the chief medical officer of HCG Strand Life Science, Mumbai. And Dr. Mina Desai will talk on the microsatellite instability in CA endometrium, which is really, really relevant present days and also for the therapeutic implications also. Dr. Mina, please.
Good evening, everyone. At the outset, let me thank Dr. Gautam, Dr. Chandan, and my old colleague, Dr. Sampada, for giving me this invitation. Can you see my screen? I'll make it full screen. Can you hear me? Yes. Can you see my screen?
Yes, ma'am. We can see your screen and we can hear you. Yeah.
Okay. So this topic, microsatellite instability, I mean, what has that got to do with endometrial cancers? This is the new buzzword around, and we've dealt with MSI and colorectal cancer for quite some time. And we wondered actually when I started doing it almost a year back, I realized that it is, endometrial cancers are one of the commonest gynecologic malignancy in developed countries. And the incidence is on the rise. So globally, 382,069 new cases were reported in 2018. Now, although the mortality is low, it has remained unchanged for quite some time. Now, coming to pathology, as a pathologist, I can say that we are routinely practicing a 2014 fourth edition WHO histomorphology-based classification. The histotype diagnosis here is there is a very high inter-observer variation. I'm sure as oncologists you are aware that a pathologist diagnoses X over here and Y somewhere else. And we also find that 30 to 50, it's nothing to shortcoming on the pathologist side, but 30 to 50% of high-grade disease are not prototypic and they do not reflect tumor biology. So prognostic separation of histotypes is therefore unreliable and inaccurate. This is the usual type 1 and type 2 carcinoma which we have seen traditionally. It was kind of classified by Boekman in 1983, and today we add on a few things like IHC markers like P53, ERPR, and P16 sometimes, but yet there is a lot of overlap. As you can see over here, there are two different types of high-grade ones. One is the FIGO grade 3 endometrioid type, and the CRES, they look very similar to anyone. So the Cancer Genome Atlas actually was a game changer. In 2013, we published an integrated genomic characterization of endometrial carcinomas based on genomic data. So it was a very comprehensive characterization, and there was definitely prognostic predictive implications as well as better risk stratification and management. So there was excellent inter-observer reproducibility. So this is the characterization, and as you can see in endometrial carcinomas, there are four major main types of molecular subtypes. There is poly, MMRD, and CNL, that is copy number low, which is not specific, and of course copy number high, which is P53 stain. This is the study which was done, and with the first one which came out, and here you find that almost 30% of the cases are MSI by the PROMIS classifier. And the main thing is that they have, along with poly, they have a better risk stratification, so better clinical outcomes. As well as Robotic 3 trials, and they have, as well as 1 and 2, have shown that 1/3 of these cases are MSI. And another classification which was published in 2018 showed that again 38% MSI, and this was done in an algorithmic way that is usually done. First is the poly hotspot mutation, followed by, if it is not there, then you do the MSI. And then you also do the P53. Here again, better clinical outcomes. Now, can they have multiple classifiers? Can one tumor have more than one molecular subtype? And what is reported now, this is the recent evidence as in Journal of Pathology in 2020, shows that if MMR deficiency and poly mutations are present along with P53, then the MMR or the poly, whichever is present, supersedes that of P53. And if both are present together, then it should be considered as MSI. You all know that NCCN guidelines have insisted that there should be a universal testing of endometrial carcinomas for MSI and MMR proteins, whichever, and testing can be performed on the initial biopsies or on the final hysterectomy. So if there's no final hysterectomy specimen, it should be performed on the initial biopsy. So now there's so much of focus on these DNA mismatch repair system. Let's just have a look at them. They are responsible for correcting all the errors and mistakes which occur in insertion and deletion post DNA replication recombination. So they are these short tandem 1,6 nucleotide bases. Now you can get two types of mutation. One is of course the Lynch, which is the inherited one, which is autosomal dominant. And you have the sporadic ones, which are seen due to MLH1 hypermethylation. So this is the profile of a Lynch syndrome associated endometrial carcinoma. You have an earlier age of presentation. They form just 3 to 5% of endometrial cancers. But one thing to remember is that they present earlier than colonic carcinomas, and they can have a synchronous ovarian carcinoma. Usually of endometrioid, but they could be of other types also. Higher grade, more frequent LBSI, and large number of tumor infiltrating lymphocyte, and greater propensity to involve the lower segment. So naturally identifying the screening, etc., is very important, especially with the family members and the individual himself, herself, for other cancers. Now, what do we see in, let's say, Lillian syndrome associated endometrial cancer? There is a preponderance of MSH2 defect, which is 57%, followed by MLH1, and then comes the MSH6, and the PMS2 is a small percentage. Now, how does sporadic differ from the Lynch syndrome, the inherited? They form the bulk, actually, of endometrial carcinoma, which show MSI high, but they are morphologically similar. The main clue is that MLH1 hypermethylation of the promoter is present. So you need to do an additional PCR test. There is no IHC surrogate marker for that, unfortunately. And again, they are shown good response to radiotherapy, and it still has to be clarified whether additional chemotherapy would help or not. And of course, there is the role of immune checkpoint inhibitors. Now, coming to the MMR and MSI testing, we have basically a tissue. That is the material which is required. So formalin fixed paraffin embedded tissue is the one, whether it is biopsy or hysterectomy. These are the 4 genes: MLH1, PMS2, MSH2, and MSH6. Absence of either one or more is equal to a mismatch repair deficient status. And immunohistochemistry can be very well performed. Here you can see the one on the left side, which is brown, is a normal expression. Here is the loss of expression. What you see brown in between are actually the stromal cells and the few lymphocytes. Now, one thing to remember is that these MMR proteins, they exist in stable forms as obligatory pairs. So if you have MLH1 absent, you also have PMS2 absent. And similarly, MSH2 and MSH6 are absent together. However, PMS2 and MSH6 can be absent without the other being absent. So these are the various combinations which you get. But one thing to remember is that MMR IHC does not exclude MMR deficiency, as there may be still functional protein, though there may be a loss of the function of the gene. This is a case of IHC where there is an isolated MSH6 loss. So what are the pitfalls? You can, I must tell you that neoadjuvant chemotherapy can give fallacious readings on IHC, and so on, poor fixation, as well as freezing the tissue for frozen section. There are other factors like internal controls being absent. And main thing is that they have 91% sensitivity. So here you have a false positive. Actually, this staining is retained in the lymphocytes, not in the tumor cell, but it can be given as negative for MSI. And here is a heterogeneous staining, which also can create a lot of confusion. So these are the various types of results which you might get. When all 4 proteins are expressed, there is no immunohistochemical evidence of MMRD, but this patient who has a strong family history still needs genetic counseling and consent and testing. Similarly, if there is a loss of MLH1 and PMS2, please do the promoter hypermethylation to bifurcate whether this is a Lynch or this is a sporadic one. Similarly, for all 4, when either of these are lost without hypermethylation MS2, they all indicate a Lynch syndrome and deserve a Lynch, this genetic counseling and testing. This is the MSI panel. I cannot go deep into it due to lack of time, but this is done on the PCR platform. The main thing it does not identify the gene of interest. It can only identify MSI tumors, which are missed also by IHC. And the main thing is that if there are 2 or more markers, which are more than 30% markers, they show, if they are lost, then they show instability. The assay, you must remember, depends on the platform. So please know which platform is used by the lab you're referring to, and the greater the mononucleotide loci, the greater the sensitivity. Should you do both MSI as well as the MMR by IHC? Well, neither test is 100% sensitive, though there is a concordance. So MMR IHC is considered actually easier to perform. It's a superior first-line test, and because of its low cost too. But of course, local resources will define your algorithm. Now, this is now the age of NGS. You can have multiple genes can be tested simultaneously, but one thing to remember, you need to have a very good bioinformatics team. I'm lucky to be at Strand, which has an excellent team of bioinformatic engineers. Efficiency depends on well-curated, clinically relevant databases. These are tumor infiltrating lymphocytes in MSI high. And of course, if there is a talk later on, which will tell you more about immunotherapy in MSI. So the take-home message is that the Cancer Genome Atlas Research Network identified two very well-defined new molecular categories, which have a diagnostic, prognostic, and predictive therapeutic usage. Around 25 to 30% of endometrial carcinoma have MSI. But of course, only 3 to 5% are Lynch associated. The NCCN guidelines have now made it mandatory to test for them. And a combination approach of both IHC and PCR for MSI, and of course MLH1 promoter methylation would be the adequate screening testing, and which should be followed by germline testing whenever there is abnormal results. And the future is, of course, we need to work on the chemotherapy aspect of it, while it is very well discussed in the colorectal cancer, but I'm not so sure about in endometrial. Of course, there is definitely an indication for potential immune checkpoint therapies. And pathologists, I would just want to tell my fellow pathologists, you need to get familiar with the MMR testing strategies and their pitfalls and facilitate a change to a more histomolecular classification of endometrial carcinoma. And working together in the tumor boards, etc., would be helpful in this stratification planning of definitive treatment for these patients. Thank you so much.
Thank you. Thank you, Dr. Mina. And I think we'll take one question from the Q&A session. So Dr. Daphne Fonseca asked, so when you have this NGS, which can identify pol P53 and all the MSI proteins and other genes, so can you test that one, or should you also test the MSI by IHC also?
Well, NGS, if it is done in a good lab on a good platform, would be naturally, as I said, no, it's a work in progress. It might even come as the frontline test. But right now, for screening, I would advise MMR by IHC, followed by, it's all a question of economics also. It's not very easy to straight away jump to NGS unless there is a very strong family history, etc. You really want to.
Thank you, Dr. Mina. I think after it's an excellent presentation by Dr. Mina about MSI in endometrial cancer, I think we'll move to the next session, which is by Dr. Binota Thomas, with the consultant gynecological oncology in CMC. So she will talk on the minimal invasive surgery in CA endometrium. Dr. Thomas, please.
Good evening, friends. And at the outset, I'd like to thank the organizers of Masterclass in Ovarian and Endometrial Cancer for giving me this opportunity to speak on minimally invasive surgery in endometrial cancer. At the outset, why do we think that minimally invasive surgery is acceptable in endometrial cancer? With the obesity pandemic in India, the incidence of endometrial cancer is fast rising. Women are obese with multiple high-risk factors, and they often have early stage disease confined to the uterus. They are eligible for laparoscopic hysterectomy, pelvic and para-aortic lymphadenectomy, and hence there is a cause for minimally invasive surgery in endometrial cancer. So the objectives of this presentation will be, is minimally invasive surgery acceptable in endometrial cancer? The utility of minimally invasive surgery, the role of minimally invasive surgery in special scenarios, and selection of patients with endometrial cancer for minimally invasive surgery. I hope I can do full justice to these objectives. When you look at the pyramid of evidence about the acceptability of minimally invasive surgery in endometrial cancer, cohort studies began to come in the last decade of the last century. Childers et al. Was the first to present this cohort series of 59 patients with clinically stage 1 endometrial cancer who underwent laparoscopic assisted vaginal hysterectomy with pelvic and para-aortic lymphadenectomy. And he suggested that laparoscopic approach was an attractive option. Soon, randomized control trials began to come in. The Gynecologic Oncology group study, or the LAP2 study, was one of the largest randomized control trial, which recruited patients with stage 1 to 2A uterine cancer or sarcoma between 1996 to 2005. The primary endpoint of this study was peri-op adverse events and quality of life. It was subsequently amended in 2001 to include non-inferiority of recurrent-free survival. The secondary endpoint was overall survival and post-op sites of recurrence. The first series was published in 2009, which showed the laparoscopic arm to have reduced moderate to severe post-op adverse events with longer operative time, with reduced post-op stay, and a fewer numbers undergoing lymph node dissection, which didn't make a difference to the stage-wise stratification. And they concluded that laparoscopy was superior, which had superior short-term safety with reduced post-op stay. The second series came in 2012, which showed identical or non-inferior recurrence-free survival and overall survival. There was another publication which showed the laparoscopic arm to have superior quality of life at 6 weeks, but was almost similar to the laparotomy arm after 6 months. The LACE trial soon followed the LAP2 trial. This was a randomized control equivalency trial, which included stage 1 endometrioid cancer between 2005 to 2010. In the phase 1 of the trial, they recruited women at 2:1 ratio, similar to the LAP2 trial, to the laparoscopic arm and the laparotomy arm. They showed the laparoscopic arm had a significant greater improvement in quality of life from the baseline in the post-op period, with similar intra-op adverse events, but with longer operative time and reduced post-op serious adverse events. Surprisingly, the conversion rate was only 6%. Conversion rate to laparotomy was only 6% because only 50% of them had lymph node dissection. The phase 2 of the trial was published in 2017. In phase 2, they randomized at the ratio 1:1 to the laparoscopic arm and the disease-free survival and overall survival with similar patterns of recurrence. Subsequently, systematic review and meta-analysis came. Fulvio et al. Along with Paloma et al. Did a systematic review of the existing trials, and the laparoscopic arm showed similar intra-op complications, but reduced post-op complications, increased operative time with a weighted mean difference of 50 minutes, but reduced blood loss. Cochrane meta-analysis finally concluded that the laparoscopic arm had similar overall survival and disease-free survival. So the evidence is there. Laparoscopic surgery for endometrial cancer is the treatment of choice and is the standard of care with level 1 evidence. The obvious advantages are there is visual magnification, there's faster post-op recovery with less post-op complications and better short-term quality of life. On the downside, there's a conversion rate to laparotomy. In the LAP2 trial, there's a 25% conversion rate to laparotomy, and this was due to increasing BMI, metastatic disease, and increasing age in descending order. There was a learning curve. There's obviously longer operative time, and definitely we need an assistant with some surgical expertise to help us with laparoscopic surgery. But with regard to learning curve and longer operative time, it definitely increases the surgical experience or the surgeon's experience, and hence the benefit of the learning curve. Often, conversion rate, learning curve, and longer operative time may be because of rigid instruments, limited degree of freedom of motion and dexterity. And this can be overcome by robotic surgery, which has got an ergonomically superior surgeon's console, camera stabilization. We don't need an assistant to help with the camera. And with the wristed instrumentation, which comes with robotic surgery, there's improved dexterity, motion dampening sensors with a robot, depth perception due to 3D camera. And the real benefit of robotic surgery over laparoscopy is that it allows performance of complex surgeries, especially in the obese and elderly with less surgeon fatigue, and it's got a shorter learning curve. This is a Danish study which showed that with the introduction of a Robo in 2005 and its FDA approval, there's a rapid uptake in robotic surgery for endometrial cancer. There's one randomized control trial which looked at robotic versus laparoscopic surgery with endometrial cancer. As mentioned previously, the conversion rate was lower with the robotic arm. Surprisingly, this study showed a shorter operative room time and a shorter operating time, including docking time. This is a meta-analysis which compared robotic and laparoscopic surgery, and it showed the robotic surgery to have shorter length of stay, less estimated blood loss, lower conversion rate, and lower intra-op complications. So when you look at laparoscopy versus robotic surgery, laparoscopic surgery has haptic feedback. This flexibility in instrument configuration. We can take out an instrument and put another instrument depending on how we are comfortable with. This, we can avoid prolonged Trendelenburg, and we can change the position of the patient depending on how she's tolerating Trendelenburg. The incisions are smaller, there's reduced post-op complications, and it is cost-effective in a country like India. And we have evidence about oncologic outcome and its non-inferiority to laparotomy. On the other hand, robotic surgery is ergonomically superior. Advanced instrumentation and camera stabilization with improved dexterity, which helps with the learning curve and especially helps MIS with the morbidly obese with BMI of more than 30. There's a lower conversion rate to open surgery and reduced post-op complications, but we have only retrospective data available with regard to oncologic safety of robotic surgery in endometrial cancer. There are few publications about single port laparoscopic surgery, but nevertheless, minimally invasive surgery for endometrial cancer is the established standard of care. When you look at established role of minimally invasive surgery in endometrial cancer, it is, as I mentioned previously, it is established for upfront surgery. We can consider minimally invasive surgery for those who come to us following an inadequate surgery for endometrial cancers and completion surgery. Another role is in sentinel node identification and dissection. In the FIRES trial, they had used all patients in the cohort underwent robotic surgery with use of indocyanine green and near-infrared imaging to detect and identify sentinel nodes. In the Senti-Endo study, majority of them, some of them had open surgery, but majority of them, about 66% of them had laparoscopic surgery with use of technetium colloid and patent blue dye. With regard to special scenarios, is minimal invasive surgery safe in high-grade endometrial cancer? In the LAP2 trial, about 9% of them had non-endometrioid histology, as against the LACE trial, which excluded all non-endometrioid histology. This was not a study endpoint, but when we look at this forest plot, there is no difference in treatment effect related to histologic cell type. But as we know, high-grade endometrial cancer is a rare histology and is difficult to conduct randomized controlled trials. There was one systematic review which was published this year, which included 9 retrospective trials. And when you look at overall survival, disease-free survival, and recurrence, MIS had comparable oncologic outcomes to open surgery. Now, the specter of LAC trial is still haunting us. So when you look at MIS, is MIS safe in clinically stage 2 endometrial cancer? Again, the only retrospective study. And this was published this year, which showed the MIS group actually had an improved survival as shown by the green curve. How do we select patients for minimally invasive surgery? Definitely patients have to be fit for anesthesia, deep Trendelenburg, and the reduced lung volume which comes with deep Trendelenburg. The second most important thing is we have to avoid peritoneal spillage of tumor. as we looked at the characteristics of studies included in the Falbo and Paloma et al. Systematic review, they had excluded large size uterus and advanced disease. Another element that we have to consider is avoid uterine perforation with uterine manipulators. Whether uterine manipulators change oncologic outcome, again, there is varied evidence, but this systematic review presented this year, which showed there was no increased incidence of positive peritoneal cytology or presence of LVSI in the final specimen or in the recurrence pattern. A special mention of port site metastasis. Isolated port site metastasis is extremely rare in both
Dr.
the
Vinata, kindly wind up.
I'm concluding.
Okay.
In MACE trial and LAPRO trial, they were very less than 1% is often a reflection of the disease. So to conclude, minimally invasive surgery endometrial cancer is safe, enhances patient recovery, non-inferior oncologic outcome, and it's very beneficial in SARS-CoV-2 pandemic because reduces the patient exposure to nosocomial infection with SARS-CoV-2. This is precautions for MIS during pandemic. I would like to thank you for this opportunity. Be safe and stay safe.
Thank you, Dr. Vinita. Thanks for the excellent presentation. As you know, this is the another option with similar oncologic outcome. So any questions, please? So I think there is no question in the Q&A or the chat box. I think we should go for the next sessions. So we have 3 plenary sessions. Thank you, Dr. Vinita, for this. We have 3 plenary sessions on the therapeutic aspects. The first is by Professor Rashmi Bagga on the fertility sparing approach. Professor Rashmi Bagga of Obstetrics and Gynecology at PGI Chandigarh. Dr. Bagga, please.
Thank you, Dr. Chandan. Thank you for this opportunity, and Dr. Gautam. And I'll start. I'm sharing my screen. Is it okay? Can you all see?
Yes, ma'am.
So my topic is fertility sparing approach in carcinoma endometrium. And just to know how often will we have to resort to this approach is that we have a low incidence of carcinoma endometrium in our country. Only 1 to 2 per 100,000 women per year as compared to a higher incidence in USA. And of these, only about 4 or 5% will be women who are less than 40 years. So we will encounter approximately 13,000 women with uterine cancer per year in India, and only 5% of them will fit in, will be less than 40 and a few of them may require a fertility sparing approach. I'm not able to, okay. So the standard approach in endometrial cancer is a surgical staging, total hysterectomy with bilateral salpingo-oophorectomy and lymph node dissection. The fertility sparing approach involves the use of progestins, and the outcome of a fertility sparing approach is comparable to hysterectomy in stage 1A only, which shows a 5-year similar survival, whether you do a standard treatment or you do a fertility sparing treatment followed by the surgery, and the survival is 97.5%. However, when the stage crosses 1A, in 1B also, the 5-year survival is lower with a progestin treatment. Therefore, the fertility sparing approach will be limited to the, sorry, I'm not able to advance my slides. We have certain prerequisites for a fertility sparing approach in endometrial cancer. And these are, this is an important slide. The patient should be of reproductive age group and strongly desiring to preserve fertility. She should be having a low risk endometrial cancer. Among the definition of low risk endometrial cancer, we have even more strict criteria for fertility sparing approach. It should be a grade 1 endometrioid adenocarcinoma, which is confined to the endometrium without any myoinvasion, and obviously stage 1A. Identify if it is a genetic cancer or not, and we can take the help of immunohistochemistry, like which was just shown earlier by Dr. Desai, and family history. It is not a strict contraindication to fertility sparing, but if it is genetic cancer, then the chances of a synchronous ovarian involvement may be higher, which has to be ruled out by imaging, by CA-125 assessment, and laparoscopy if required. The patient should not have any contraindication to hormone therapy because we use high doses of progestins, which have got their inherent problems like causing thrombosis and altering the metabolic profile. And the counseling should be important. The patient should understand that this is a non-standard treatment where the standard treatment has got very high oncologic good outcomes. The risk of occult cancer may be there, which is missed because the staging in this approach is by a clinical method and not by a surgical staging. And there's a risk of persistence as well as recurrence. If she understands all this and she is strongly desirous, then we will select this patient for a fertility sparing approach. I'm having a problem with moving. So as I said, it should be a grade 1 cancer identified on endometrial histology. And this endometrium should have been obtained by a DNC and not by an office EB, because an office EB is not as sensitive. It may not pick up the entire area, and we need to know that which is the worst area in grading. And DNC has definite better diagnostic performance because the final pathology at hysterectomy has been upgraded in more women when office EB was done initially as compared to DNC, 17.4 versus 8.7%. However, in 1% cases, whether you do a DNC or EB, a higher grade histology has been seen in hysterectomy, which was not picked up earlier. In case you want to add hysteroscopic to the DNC, it may be even better. It will sample all areas, but it is not mandatory. So the other cornerstone of selecting women for fertility sparing is imaging. And it was very nicely shown in a previous slide that imaging by MRI is the method of choice because MRI is superior to ultrasound to pick up myometrial invasion with a higher sensitivity of 89% and specificity 100%. It can pick up loco-regional disease spread, cervical extension, deep myometrial invasion, or enlarged lymph nodes. There are some newer MRI techniques which will add to the specificity and sensitivity of MRI, and one of them was discussed earlier, the diffusion weighted imaging, and the other is T2 relaxometry. This will come up, and they help to identify the endometrial myometrial junction very clearly. I will just show a picture of the T2 relaxometry in which there's a fourth myometrial layer which is identified just within the junctional zone, between the endometrium and the junctional zone, which will pick up any myometrial invasion. So we will have a better selection of patients for fertility sparing surgery. Once we've selected the patient, the management plan would be check that she fulfills all the criteria and progestin therapy. In addition to it, since many of these women will be having PCOS, obese, advise them lifestyle modification and use the time of 6 months to work up for infertility, if any, like a male factor, and treat it if needed. And the steps in treatment are to treat the carcinoma, check its reversal, and this is followed by ART. The management plan would be that the option here is progestins. The standard of care is oral progestins, and 2 progestins have been commonly used, the 21 hydroxyprogestins, medroxyprogesterone acetate, MPA, or megestrol acetate, MA, and the doses used are very, very high, which have got side effects in the form of thrombosis and metabolic, like I mentioned earlier. Continuous treatment is more effective than cyclic. The advances here, or which make more sense, is addition of a local progestin releasing device, a levonorgestrel IUD, which can be combined either with GnRH agonists or with oral progestins. Now, this intrauterine device has been less well investigated in oral progestins and has been found to be better in endometrial hyperplasia because the regression rate is better to the tune of 95% versus 25% with oral progestins, but not so in endometrial carcinoma at present, where a small study showed a 33% regression with LNG20 alone, but when it was combined with oral progestin, the regression rate was higher to 78%. So at present, it has been used in some situations in combination with oral progestins or with GnRH agonists. There are some ongoing trials where LNG IUD is being tried alone or along with metformin plus lifestyle modification, which will give us an answer later on whether it is superior to and whether we can use it along with or on its own for fertility sparing treatment. I don't know why my slides are getting. Is the time over?
Ma'am, please use keyboard to change the slides.
Yes.
Ma'am,
So
please change.
Sorry?
Please use keyboard to change your slides.
I'm using the keyboard. Okay. So the conservative treatment which we are going to select, the treatment regimen, should match the high survival of the standard surgery. And a limited data shows that combination of LNG20 and oral progestin has a slightly higher response rate than oral progestin alone, though at present oral progestin alone in high doses is standard of care. The options can be either oral progestin alone in the doses I mentioned earlier, or we can try LNG IUCD along with a lower dose of megestrol or MPA. But we have to remember that the LNG IUD may be less effective if the cavity is enlarged because it may not treat the lesion beyond the range of the device. In addition, other adjuncts have been tried, like addition of aspirin, lifestyle modification, and metformin to reduce the risk of endometrial cancer, which was caused by these predisposing factors earlier. The response has to be assessed after minimum of 12 weeks of therapy, or at 8 weeks of treatment. Some studies have shown that a thinner endometrial stripe may be a better predictor of response. 6.5 mm showed a 73% response versus a thicker stripe of 14 mm, which showed a 25% response. An office EB will be done after 3 months, and if she has an LNG IUD, then it can be done with the IUD in place, which is retained. If we find a complete response, continue the same treatment and repeat an EB in 3 more months, that is at 6 months. So after 2 negative consecutive EBs, we can pursue a pregnancy as soon as possible. And if she doesn't wish to conceive immediately, IUD may be left in place. If the disease is persistent at 3 months, then it is better to increase the dose of progestins and repeat an EB after 3 months of change in therapy. However, in no condition, the therapy should be continued beyond 9 or maximum 12 months, and then she is a candidate where hysterectomy is advised as the treatment has not succeeded. Other options which are still not accepted uniformly is estroscopic resection of endometrium and superficial myometrium. It may help in some initial non-responders, especially in a unifocal lesion, but there's a risk of placenta accreta in a future pregnancy, and it's not a standard treatment at present. The reproductive outcome in fertility sparing has been shown to have a pregnancy rate of about 35% in older data, which will be maybe better when newer data comes up, and a similar live birth rate, and a median response time of 12 weeks with pregnancy documentation available in 20 women in a large review. We also found that 24% of the initial responders recurred, and therefore a recurrence risk is also 1/4 of the initial responder, but no patient died of disease. So subsequent treatment after childbirth or after the age of childbearing is over is total hysterectomy with BSO. This is advised because of a high recurrence risk of 25 to 30%. And the ESMO guidelines, the STU 2014 and NCCN all recommend this. However, now there is an option of ovarian preservation in selected cases depending upon age and genetic risk factors. And these women will be the one who are aged less than 45 years with grade 1 endometrial cancer with myoinvasion less than 50% and no obvious ovarian or extrauterine disease. This has come up because it has been seen that if a woman is less than 45 years of age and there was no intraoperative evidence of extrauterine disease on extensive exploration, then the risk of coexisting ovarian malignancy had dropped to 0.97% or 0%, which was otherwise higher to 7.3%. So given this finding, some of the women can be selected for this purpose also, and here the ovary may give a function of hormonal as well as for a possible oocyte retrieval and surrogacy later on. So an experience in PGI, over the last 10 years, we had 23 women whose records I could retrieve less than 40 years, of whom 12 were given fertility sparing treatment. Of these 12, 2
Yeah, sir, I guess Dr. Rashmi has lost his internet connectivity.
Wait for a minute, no problem.
Well, 40 minutes just.
Okay, yeah. Ma'am left the meeting. Maybe she is rejoining.
Oh, sure.
Yes, yes.
Rashmi ma'am joining.
Of treatment. Oral progestins alone are the standard of care, but now they can be combined with LNG IUD, and more data will emerge in the next couple of years. And during 6 months of treatment, to reverse the endometrial cancer, please pay attention to other factors like lifestyle modification and other fertility factors. And after childbearing is completed, standard surgery is recommended in the form of hysterectomy with BSO. Thank you.
Thank you, Rashmi ma'am. I think it's
I think I had some problem with connectivity. I'm sorry for that.
No problem, it's fine. I think the fertility preservation options are the ray of hope for the many young women who want to preserve their fertility, want to become pregnant. I think these are the options. So I think we take a question from the Q&A. So what is your experience? What is your preference, Mirena or the oral progesterones?
For me, I showed you the 3 patients where we used it, and we prefer to give a Mirena along with oral progestins together, but where we can use a lower dose than if we give them alone. And we also strongly advise weight reduction, lifestyle modifications, and if they are on metformin for some reason, we like to add that also. This is our experience.
Thank you, ma'am. I think after the excellent talk, we'll go to the medical oncology aspect. So it will present by Dr. Vineet Talwar, the Director of Medical Oncology in the RGCI New Delhi. So he will talk on the immunotherapy aspect of CA endometrium. And perhaps Dr. Talwar, please.
Thank you, Dr. Chandan. And the topic which I have been interested is the role of immunotherapy, the clinical aspects in endometrial carcinoma. So, you know that endometrium is a disease which has a lot of genomic instability which is inherent in it. There can be resultant phenotypes in the sense that you can have nucleoside instability or chromosomal instability or microsatellite instability. Amongst these, the endometrial cancer has the highest rate of microsatellite instability which is observed, which you can see here. And amongst all the cancers, the uterine endometrial corpus adenocarcinoma, you can see, has the highest number of cases as compared to the other 39 human cancer types. Also, along with that, it has a high PD-1 and a PD-L1 expression level, which can be used when we give the immunotherapy drugs. In the various types, that is serous, endometrioid, and clear cell type, you have a range of about 20 to 80% between all these three. And these also can be exploited whenever you give treatment for endometrial cancer. And now coming to the immune checkpoint blockade in these tumors. The somatic mutations can be recognized by the immune system. The MS-high tumors carry about 10 to 100 times as many somatic mutations compared to the normal cells. And thus, since they have more than 20 times as many mutations, the higher the mutational burden, the higher is the translation to more immune activity, and that is the reason why immunotherapeutic drugs can be exploited. And MSI high tumors have a prominent lymphocyte infiltrates, which again lead to the priming of them to the immune related activity. So when you see the classification, the latest classification, which is the molecular classification of TCGA, that is the Cancer Genome Atlas, you find that two of them, which are MSI stable, copy number low and copy number high, they are the ones where we cannot exploit these immunotherapeutic drugs. But if you see the pole type, which has a combination of MSI high, low, and stable, and also the MSI high group, you find these are the areas where potentially you can use these immunotherapeutic drugs to the advantage and get the maximum benefit out of it. So with this in mind, a study was done in 2016. This was the first study in which a lot of cancers, that is solid tumors, they were checked. All of them had been censored for the MSI high or deficient MMR. And amongst these, 27 patients were the ones with endometrial cancer. And these were, mind you, very heavily treated patients. And it was found that amongst these patients, there was an overall response of about 57%, in which CR rates were 16%, which were never heard of. So this trial led to the approval of pembrolizumab as a treatment option for MSI high tumors in recurrent or metastatic endometrial cancers in second line and on so forth, as an agnostic cancer drug approval. So this was the first time where an agnostic cancer drug approval was done. Agnostic means I don't know the site of the tumor, but if you have the marker, then I'm going to act surely. So 2017 was the watershed area which paved for the further trials in which it was checked as a monotherapy. And after that Keynote 158 trial, Keynote 28 trial was there. This was a phase 1B trial in which 24 patients were subjected to pembrolizumab. This was 10 milligram per kg every 2 weekly up to 2 years, 24 months. And this was irrespective of the MSI or the MMR. And in this, it was seen that it had a stable disease of 2 patients, partial responses in 3 patients with an overall response of 13%. The 6 months progression-free survival was about 19% and overall survival of 68.8%. Another drug which was there, that was dostarlimab. This was again checked as a monotherapy in phase 1 bar phase 2 study, and that also showed that the overall response was about 49% and the median duration of response was not reached. So with this in mind, when the immunotherapeutic drugs were used as monotherapy, a thought process was whether we can combine it with some other drugs to increase the potentiation. The thought came whether we can use immune checkpoint inhibitors as a combination instead of monotherapy. The rationale for that was that chemotherapy results in immune stimulation. And along with that, there is an enhanced presentation of tumor cells, specific antigens, which induces PD-L1 expression on cancer cells. And once this is done, there is a disruption of the tumor stroma, and it increases the penetration of the cytotoxic T cells which are present. So following this, a landmark study was done, which was the Keynote 146 study. In this, you can see these were the patients with adult metastatic endometrial cancer who had a good performance status and who were not MSI or deficient in MMR. So these were the patients who were taken, who had less than 2 previous lines of therapy and subjected to pembrolizumab, which was the immuno-oncology drug, along with lenvatinib, which is a TKI, tyrosine kinase inhibitor. So 200 milligram of pembrolizumab with 20 milligram of lenvatinib were given to these patients until progression or intolerance. And these were basically divided into 2 groups. Subgroup 1 was the one which had metastatic or advanced disease. Subgroup 2 were the ones which had local disease or loco-regional disease. An analysis was done at about 6 months. And this was the baseline characteristics. You find that both the subgroups, that is subgroup 1 and subgroup 2, they were equally divided. One was the one which had the advanced group, 2 was the one which had the loco-regional group. And also all these patients which were included, they included endometrioid serous clear cell carcinomas. There was a good performance status in this, and PD-L1 positivity was about 50% in both the cases. And also it was found out that the overall responses in this were more in subgroup 2, in which the disease was loco-regional, as compared to subgroup 1, that is 57.1% versus 41.3%. And this was an eye-opener because as compared to the single-digit responses which were seen with the single immuno-oncology drugs, when you combine that with lenvatinib, you had a remarkable increase in the overall responses. As far as the safety profile was concerned, we found that the 3 deaths were in the subgroup 1, in which there were advanced disease, and 2 deaths in the treatment-related sepsis which was there. But most of these side effects were very well tolerated. And subsequently, the conclusions were, the investigator concluded that lenvatinib and pembrolizumab showed promising efficacy as an early line treatment, that is less than 2 sets of treatment in patients with advanced endometrial cancer. And the beauty of this study was there was no need for MSI high or dMMR, which was initially done in 2016 in the agnostic study. And safety profile was consistent with the broader population, and efficacy in subgroup 1 was consistent with the broader population of the endometrial cancer patients, which included more heavily pretreated patients. So in this, you had 2 cohorts of patients, one who had loco-regional disease, the others who had metastatic disease. Both fared very well when this combination was given, both tolerated very well. And subsequently, after this, the FDA granted approval to lenvatinib and pembrolizumab in advanced endometrial cancer. And this has, as you see, can be seen in the NCCN guidelines, and it has been incorporated here, useful in certain circumstances, pembrolizumab and the others with lenvatinib, in which it can be given as a single agent or in combination. There are a lot of other studies which are going on, phase 2 bar phase 3 studies, in which like this study is there with dostarlimab. This was initially tested as a single agent. Now it is being combined with paclitaxel and carboplatin. And this was again pitted against this standard paclitaxel carboplatin, 1:1 randomization, and the results have yet to come. Another study in which another immuno-oncology drug which is there, atezolizumab, this is combined with the standard which is paclitaxel and carboplatin. And after the completion of 6 cycles of chemotherapy, atezo will be given as a maintenance till progression or till confirmed responses. The third study is again pembrolizumab. This is now combined with paclitaxel and carboplatin. And this was stratified according to the MMR proficient versus the MMR deficient status. So these three studies are the ones which are ongoing. As of date, if immuno-oncology drugs have to be given, it is a combination of pembrolizumab plus lenvatinib, which need not have MSI or MMR. If it has to be given as a single agent, then definitely you have to document the MSI or the MMR, and then it can be given as an agnostic agent, although the response rates will be very less. So to summarize the future directions, they are towards the tumor mutational burden, the MMR, the PDL1, and the tumor infiltrating lymphocytes, because wherever there is high immunogenicity, that translates into good immunogenic response, and that is the place where the immunotherapeutic drugs are going to work. The other areas which are being worked upon are the vaccine strategies, because these are very immunogenic tumors. So is the adoptive T cell approaches. Very deep thought is being given to delineate the mechanisms of resistance, why they occur in these patients of endometrial cancer. So it is going to be very interesting as to how these things shape up in the near future, especially once the phase 3 studies come into vogue. I thank you for your patient hearing.
Thank you, sir. It's a eye-opener, at least for the MSI high ovarian cancers. So we'll take one questions from the chat box and the Q&A sessions. So there is a question. So if your patient is relapsed endometrial cancer, which is MSI high, what is your preferred option, whether it's a pembrolizumab or pembrolizumab with lenvatinib?
If you go by this data, this kind of data is path-breaking data. Definitely, as the studies showed, that you give this combination in less than 2 sets of chemotherapies. Definitely, if patient has received one set of combination chemotherapy, I would love to give this combination.
Thank you, sir.
Thank you.
Thanks for the nice talk. So we'll move to the third plenary session, so which is by Dr. Umesh Mohanty, the director of Homi Bhabha Cancer Hospital and Research Center in Vizag. So Dr. Umesh is the professor of radiation oncology. He's going to talk about the POTEC 3 trials, the past, present, and the future. Dr. Umesh, please.
Thank you, Dr. Chandan Das. Can you see my screen?
Yes, please.
Yes. So at the outset, I would like to thank Dr. Gautam and the organizers for giving me this opportunity to present. And the mandate given to me is to discuss about POTEC 3, past, present, and future. And I have 15 minutes and no financial disclosures. To set the ball rolling, this is a slide which summarizes, as of today, what is the consensus and recommendations for various stages of endometrial cancer after adequate surgery. And what is shown on the left is the risk stratification according to ESMO, Estro, and ESGO. And on the right are various stage and other factors which are utilized to classify them into various risk groups. And on the right extreme are the treatment which are more or less standard of care as of today. So for low risk, surgery alone is sufficient. For intermediate risk, which consists of stage 1B, endometrioid, grade 1, grade 2, LVSI negative, vaginal brachy. For high intermediate group, which accounts for 35%, maybe in India, 50% in this category. And these patients can also be conveniently be treated with either vaginal brachy or pelvic IMRT, depending on the high intermediate risk. What is important and relevant to my presentation is the high risk group, which consists of stage 1B endometrioid with grade 3, regardless of LVSI status. That's the first group. Second group is stage 2 and stage 3 with no residual disease. And the third important group is type 2 histologies, namely serous, clear cell, undifferentiated carcinoma, and carcinosarcomas. And for this high risk group, of course, radiotherapy has to be given in post-op adjuvant setting. However, what is controversial is that whether radiotherapy alone suffices or chemotherapy alone or combination of chemo radiation is what is the most contentious issue which has been dealt in detail now in last couple of years. And this has been possible because of two large randomized trials which have been published last year. And the first one is the POTEC 3 trial. And the background was the phase 2 RTOG as well as the phase 3 small numbers of NSGO, Norwegian and URTC trials, which suggested a benefit, survival benefit in favor of chemo and radiation. However, what was not clearly defined was the sequencing and the schedule of radiation and chemotherapy. And more importantly, you should also remember that elderly patient group, the quality and the toxicity of the treatment is also of a major concern. So the hypothesis set in POTEC 3 was to detect a 10% difference in survival with a standard power of detection of 80% with alpha of 0.05. And what is important to realize is that this was this trial had a co-primary endpoints of both overall survival and failure-free survival, which means both of these endpoints should be positive to claim it as a positive trial. If neither of them satisfies the hypothesis, then it's a negative trial. The secondary endpoints were the recurrence patterns, treatment-related toxicities, and QOL. This is a slide which shows essentially the inclusion and exclusion criteria. The inclusion criteria are nothing but the high-risk group, which I mentioned earlier. What is important in inclusion criteria is that there was a central pathology review before randomization. So suffice to say that there was no bias in, let's say, there was uniformity in the inclusion criteria. And the exclusion criteria were standard other histologies. And for chemotherapy, neuropathy or hearing loss were the exclusion criteria. And the design of the trial was that the post-operative pelvic radiation was considered as the gold standard arm. And it consisted of 5 weeks of pelvic radiation to a dose of 48.6 to roughly around 50 gray, which is sufficient to treat microscopic disease. And the study arm defined was pelvic radiation along with 2 cycles of cisplatin, 50 milligram per meter square, given in in week 1 and week 4. And this was followed by 4 cycles of Paclitaxel carbo with 175 milligram of paclitaxel and carboplatin AUC of 4 into 4 cycles after a gap of 2 weeks after completion of chemo radiation. And this was a multicentric international trial. More than 103 centers participated in this study. And the study randomized roughly around 660 patients into pelvic radiotherapy alone and chemo radiation followed by adjuvant chemo. What I've highlighted here is that definitely in this trial, elderly patients were on a higher side. And if you see carefully in this table, more than 50%, roughly around 60% of the patients were aged more than 60 years. Most of them were in good performance status, and comorbidities in terms of diabetes, hypertension was roughly around 35 to 40%. This is a slide which summarizes tumor characteristics and treatment characteristics. If you carefully see the tumor characteristics, roughly 30% of the patients were grade 3, 30% were of type 2 histology. And if you see the stage 3 accounted for approximately 50%. And stage 1, stage 2 accounted for another 50%. And what is important in treatment characteristics is that roughly 60% of the patients underwent lymph node dissection and remaining 40 did not undergo lymph node dissection. And at the last corner is the compliance to CT. 2 cycles of concomitant CT was feasible in 92% of the patients, which is quite good. However, the adjuvant 4 cycles of carboplatin and paclitaxel, the compliance rates were lower. It was 79% for carboplatin and 71% for paclitaxel. So roughly around 25% non-compliance to completion of 4 cycles of adjuvant chemo in the form of pacli-carbo. These are the Kaplan-Meier curves showing the co-primary endpoints of overall survival on the left and failure-free survival on the right. And what they showed was there was a significant improvement in both overall survival and failure-free survival to the tune of 5% and 7% respectively in favor of patients receiving concomitant chemo followed by adjuvant chemotherapy with a p-value which was adjusted was 0.03 for overall survival and 0.016 for failure-free survival. When they did a subset analysis, which was, I think, planned, and what they showed was that for stage 1 and 2, there was no significant improvement in both overall survival and failure-free survival. And you can see very well these Kaplan-Meier curves, which are more or less hugging each other with p-value not significant. What is also striking is that in this trial, for the first time, they showed that this chemoradiation protocol is definitely better for stage 3 patients with no residual disease, and the magnitude of benefit is 10% in overall survival and 12% in failure-free survival, with a p-value significant in both the curves. Also, as I mentioned earlier, that 50% of the patients had type 2 histology. So these are the curves which show that the advantage of concomitant chemo followed by adjuvant chemo was higher in type 2 histology to the tune of 18% overall survival benefit and 12% failure-free survival benefit at 5 years in favor of chemoradiation. For the secondary endpoints, what I've highlighted here is, since both the arms had pelvic radiation, there is no much significant difference in vaginal or pelvic recurrence. However, if you carefully see the distant recurrences reduction is seen in chemoradiation by roughly 6%. However, it is still not significant. There were severe adverse events in concomitant chemoradiation arm. I will not go into the details, but suffice to say that patients who received chemoradiation had significant grade 3, grade 4 toxicity to the tune of 60% overall in chemoradiation arm as compared to 12% in radiation alone arm. And these toxicities were mainly in the form of the hematological toxicities as well as the grade 3, grade 4 neuropathy because of paclitaxel. For the quality of life, yes, of course, we all expect that concomitant chemoradiation patients' quality of life will be definitely inferior, but with time, it recovers roughly by 18 to 24 months. And same is true for neuropathy. However, the neuropathy, significant neuropathy stays back in patients who receive concomitant chemo because of the paclitaxel, and the difference is 25% versus 6%. The other trial which parallelly was published and discussed is the GOG 258. I will not go into the details because of my topic, but what I wanted to highlight was there is a myth that these patients are more advanced. Of course, the eligibility criteria was more advanced, but if you carefully see, these group of patients in 258 have higher stages, no doubt, 3A, 3B, 3C1, and 3C2, and 4A. But what is important to see, even in this trial, the type 2 histology accounted for 30% roughly, and these patients were stratified for even gross residual disease. However, if you see in the lower part, gross residual disease was present only in 2% of the patients across the two arms. So suffice to say that these group of patients also have significant stage 3 disease with no residual disease. And what they showed was the randomization was between the adjuvant chemotherapy, which was considered as gold standard treatment of 6 cycles of paclicarbo, similar to POTEC 4, but here the number of cycles was 6, whereas the study arm was concomitant chemoradiation, which is nothing but POTEC 3 study arm, similar to that. So what they showed was there was no significant difference in the outcome for recurrence-free survival, which was the primary endpoint. However, vaginal recurrences, pelvic recurrences were higher in patients who did not receive pelvic radiation, whereas patients who received adjuvant chemotherapy alone had significant improvement in distant recurrences. And this is a forest plot which shows that the outcome was more in favor of chemoradiotherapy for more advanced disease, that is stage 3C, and serous histologies or type 2 histologies. Suffice to say that chemoradiotherapy definitely improves the outcome in stage 3C and type 2 histology. But what is striking is shown in this graph. On the left is the POTEC 3 Kaplan-Meier failure-free survival for patients who were stage 3 with no residual disease. And on the right is the patients who are more or less stage 3 in GOG-258. The striking difference is that the 5-year survival is so different between these two, which needs to be dealt into detail. And unfortunately, going through the papers, there is no much difference. Probably there is some difference in the spectrum of stage 3 disease across the POTEC3 as well as GOG-258, which remains unexplained. What I did was I did combine these two studies, and this is the following analysis. POTEC3, the standard arm was RT alone, and the study arm was CTRT. In GOG-258, the CT alone was the standard arm, and the study arm was CTRT. And I've clubbed the CTRT arms in the center. And what is striking is that patients who have a component of pelvic radiation, whether it is RT alone or CTRT, the pelvic recurrences in the form of vaginal as well as pelvic recurrences are quite less. And this looks like significantly less as compared to patients who are not receiving pelvic radiation, and the last arm is chemotherapy alone. And if you carefully see the systemic relapses, in patients who have received chemoradiation, the systemic relapses is roughly around 23-24% together, GOG-258 and POTEC3. Whereas in patients who have received CT alone, that is 6 cycles as compared to 4 cycles of paclitaxel, the systemic relapses is around 21%. And in patients who do not receive systemic chemotherapy but receive only locoregional radiotherapy, the systemic relapses is 29%. So suffice to say that if you give pelvic radiotherapy, there is a reduction in locoregional relapses of 14% as compared to the chemotherapy alone. And secondly, if you give chemotherapy alone, there is a modest reduction in systemic relapses with the chemo, and that compared to RT alone, roughly around 6%. And most important thing is at the bottom, the grade 3, grade 4 toxicities is quite high, irrespective of whether you give chemoradiation or chemotherapy alone. And this is quite significant in this group of patients. So the question is always, what are the logistics and practical implementation? Unfortunately, in our country, we always still struggle with these issues. For example, adequacy of surgery, especially lymph node dissection, whether pelvic with or without para-aortic. Secondly, there is no uniformity in histopathology reporting, especially, for example, LVSI, type 2 tumors, and grade. There is a major discrepancy in definition of grade 3 across various labs in the country. And what we also lack is appropriate referral and tumor board discussions to find out what is the appropriate treatment. And the last part of the slide shows so many treatment options which are available for these more advanced disease. Chemoradiotherapy followed by chemotherapy like POTEC3, then GOG-258 where we are giving 6 cycles of chemo, then GOG-249 where vaginal brachytherapy is followed by 3 to 4 cycles of chemotherapy for stage 1, stage 2, and then the other treatments which are usually practiced, which we come across in this country, are chemotherapy followed by radiotherapy or radiotherapy followed by chemotherapy. So there is no consensus as to what treatment sequencing should be done. Nevertheless, what we find, the treatments which are offered in various parts of the country as well as outside this country is shown in this table. So what we do is we try to find out the exact stage, and patients with stage 1, grade 3 with more than 50% myoinvasion, regardless of LVI status, this is the first group of high risk. We look at the surgical staging. If it is done and negative, we usually try to offer them pelvic EBRT limited portals so that the toxicities of pelvic EBRT is minimum. If you feel that the surgery is adequate and adequate number of nodes have been sampled, then there is an option of vaginal brachytherapy alone. If the pelvic dissection is not done, then these patients would definitely require pelvic external beam. And in this group of high risk, chemotherapy is not yet proven in the randomized trials. For stage 2 with myometrial invasion, regardless of LVI status, again, if the lymph node dissection has been adequate, then for patients who have grade 1, grade 2 and LVSI negative, where we usually tend to give vaginal brachy alone, whereas patients who have higher grade, that is grade 3 or LVSI positive, we tend to give pelvic external beam radiation with or without vaginal brachy, depending on the adequacy of the cuff for stage 2. If the pelvic dissection is not done, definitely these patients go for adjuvant pelvic radiation. And for grade 3 or LVSI positive, adjuvant chemo may be considered, especially after completion of external beam. But for stage 3 group with no residual disease, we usually ask for a POTEC 3 protocol like chemoradiation. However, in Tata Hospital, I remember the discussion with medical oncologists and gynecologist, and we always think about the compliance to treatment. So there was some consensus that we could offer them paclitaxel 4 cycles with 175 milligram per meter square paclitaxel and AUC carboplatin of 4 cycles, followed by pelvic radiation or extended field radiation, depending on the nodal status. And for type 2 histology, we usually try to classify them into early, that is stage 1 with LVSI negative. And if lymph node staging is done adequately and it's negative, we tend to give brachytherapy alone. Whereas if pelvic lymph dissection is not done, then these patients would go for pelvic external beam, and chemotherapy is still investigational and could participate in ongoing research studies. Whereas for patients who have more than or equal to 1B, irrespective of other factors, these patients usually are treated with combined modality treatment. And as I mentioned earlier, as we do for stage 3, we usually give them 4 cycles of paclicarbo followed by pelvic radiation. And chemotherapy alone is usually reserved for the other histology, more aggressive histology like undifferentiated carcinomas or carcinosarcomas. And if patient tolerates chemotherapy well, then they are topped up with external beam radiation. A couple of slides on what is happening now is the task group cancer analysis, which have shown various subgroups depending on the molecular characteristics. And this is an example of the outcome analysis of POTEC 1 and 2, 834 patients, where they have shown that patients who have P53 mutations have higher chances of local recurrence, distant metastasis, as well as poor overall survival. And this is quite exciting in today's era because this is irrespective of staging. And then when we go into the details of other markers and other histologies, there is data which says that patients who have P53 mutations, as well as the other histologies, the outcome is definitely inferior, whereas patients with poly mutations as well as MMR deficient do relatively well compared to P53. Similar analysis was done for POTEC 3 molecular subgroups, and what this slide shows is that looks like P53 mutated patients who have stage 3, aggressive chemoradiation seems to be significantly better outcome as compared to patients who receive pelvic radiation alone. Suffice to say that maybe apart from the staging, maybe if we are able to do these molecular markers, especially if P53 status, then we could selectively treat these patients with more aggressive treatments. And this is what is shown in these patients who had P53 mutations, and you can see that concomitant chemoradiation had a significantly better outcome in relapse-free survival as compared to pelvic radiation alone. On similar lines, we have the hormonal receptor status, and if patients who have receptor status deficiency, there are studies now which are ongoing for evaluation of use of PARP inhibitors like olaparib and niraparib, where it could be utilized in treatment of these more aggressive tumors, especially the type 2 histologies. And another example, if the tumors show the presence of HER2 positive, then maybe there is a scope to add the trastuzumab along with the standard paclicarbo especially in advanced as well as recurrent tumors. So in summary, definitely for high-risk endometrial cancers, we need aggressive treatments after initial good surgery and good histopathology report. And what we learn from POTEC 3 now is that adjuvant chemoradiotherapy, especially for stage 3 and type 2 histology, is quite useful for significantly improving the outcome as compared to radiation alone. However, one should always remember that this is associated with significant toxicities, especially the hematological as well as peripheral neuropathy. And these patients would need some active support during the treatment. Considering GOG 258, CTRT is not superior to chemotherapy alone. However, the world is still divided as to which patients should receive chemo alone versus chemoradiation alone versus chemoradiation because of these high risk features of the local as well as pelvic recurrences, and a modest improvement in the systemic relapses. What still remains to unanswered or unresolved is the sequencing of chemoradiation. And last but not the least, according to me, apart from this staging, the molecular markers are going to be game changers in future to decide on adjuvant treatment. And I can tell you that there is a lot of discussion currently happening in European community to change the staging entirely to molecular staging for endometrial cancers. I thank you for your attention.
Thank you, sir. Indeed, a comprehensive review on the POTEC3 and the approach to the endometrial cancer, especially in those who have been the poor risk patients. So we'll take one question from Q&A. I think we have a questions. So Dr. Cannon asked, the lymph node dissections decided by the stage, right? So it's as for the POTEC3, almost 40% didn't have any regions, didn't have the lymph node dissections. So can you elaborate on this? POTEC3?
So I think in POTEC3, since it was a multicentric international study, more than 100 institutions were participating. Certain institutional protocols were followed, especially in the Dutch society, where the lymph node dissection was at the discretion of the institution. And this probably was decided by the fact of early stage 1 and stage 2, who may not have required lymph node dissection when they decided for the treatment. So it hardly matters, because the subgroup analysis showed that in stage 3 the outcome is better, and stage 1 there's no big difference. Whether even if I classify them into lymph node dissection versus no lymph node dissection, maybe the outcome is still similar.
Thank you. Thank you. I think we end here the plenary sessions. I think we go for the great debate, and thank you, Doctor. Thank you. Thanks for this. I think we will go for the next session, which is great debate. And for this, I would like to invite Dr. Sampada to moderate the sessions. Dr. Sampada, it's like going to moderate the sessions for the great debate.
Thank you, Dr. Chandan. Now we have a great debate. The debate is on the role of lymph nodal dissection in early stage endometrial cancer. To debate, we have Dr. Vijay Justi, Consultant Obstetrics and Gynecology at Vardhaman Mahavir Medical College and Safdarjung Hospital, Delhi, who will speak for the lymph nodal dissection. And the contrary view will be given by Dr. Nirja Bhatla, Professor and Head of Department of Obstetrics and Gynecology, AIIMS, New Delhi. This will be followed by 2 minutes rebuttal by Dr. Justi. So I'll ask Dr. Vijay Justi to take over the session.
Can you see my screen, Sampada?
Yeah.
Okay.
Well, we can't see the screen, Vijay.
You can't?
No.
Sampada, they can't see the screen. Can you?
It's with...
No, ma'am, we can't see your screen.
I have already sent my slides also. I will again do it. I'm clicking on slide share. Is it visible now?
Yes.
Yes.
Yeah. Yeah, all right. Thank you so much, Dr. Gautam and the organizers, for giving us an opportunity and debate against a friend. That's going to be, that was a pleasant surprise, Nirja. Anyway, I think my job has been made a little easier by Dr. Umesh, his concluding slides. So I am in another 8 minutes, I'm to defend that we have to do lymphadenectomy in early stage endometrial cancer. How? By my saying that we have to do it doesn't prove the point. So what has happened, the management of endometrial cancer has changed, has taken a lot of changes over the last 25 years. So, GOG33, when earlier it was a clinical staging, then GOG33, they found that there were a lot of lymph nodes positive in these cancer patients where they were earlier doing only THBS or with vaginal cuff. I think when I was a student back then, it was a vaginal cuff. So then the FIGO, it made the, FIGO to think that you have to introduce the surgical pathological staging, which was done in 1988. But it was further revised in 2009, and where they said the stage 1 disease, that means it is limited to the uterus. When we talk of early stage, that means it is only uterus. Now in uterus, it can be myometrium, superficial, deep, or it can be in cervix. So stage 1 and 2 have been clubbed together in an early stage, so to say, because when we say early stage, then I don't think Nirja will be having only little part of it to defend, because in early stage, it is only low risk where we are saying that we do not have to do lymph node dissection. Now this peritoneal washing, which was also introduced in 2009, has also been changed again in 2018, and no better person than Nirja will know it, because she was part of making those guidelines. Whether you have a peritoneal cytology positive, it doesn't change the prognosis, but in any way, it is part of the staging when we are doing. So several retrospective studies have led to the crescents to the idea that surgical staging with lymph node dissection can only assist with directing post-operative adjuvant therapy. This is exactly what Dr. Umesh was telling before me, that systematic surgical management with lymph node biopsy will, decide later on that whether you have to give her an external beam radiation or you have to give her selective. So when you're giving an excessive radiation, then definitely the complications will increase. So now, which patients we can avoid this? I'll come to that. Now, if you have patients with deep 1/3 invasion, they will have 25% lymph node involvement, and they will also have periodic lymph node involvement, which was reported in 2015. And the grade of the tumor also constitutes an important prognostic factor, which all of us know. Despite the subclinical rate of extrauterine disease, the majority of patients will have organ confined disease, but that doesn't mean that it is low risk. Now, what are the drawbacks of not doing lymph node dissection? Inaccuracy of preoperative imaging, we know that we had a lecture before that MRI, it's only maximum you can stretch it up to 90%, where you will get the exact status of the lymph nodes. Then you are doing intraoperative assessment. Then how much you to rely on a frozen section? Only 10% of the patients of lymph node metastasis have a clinically palpable lymph nodes when we rely on that. Then inaccuracies in determining the grade of the lesion and depth of the myometrium in frozen section has been reported to be as high as 30%. Now, there are different retrospective studies. There are more retrospective studies which have supported that lymph node dissection has to be done in early stage cancer, like this in 2005, where they said that if it is a microscopic disease, the 5-year disease specific survival definitely will go down from 63 to 43%. Similarly, in 2003, if you have a complete lymph node dissection, the disease-specific survival will go down to 8.8% compared to 37.7%, where you note the complete status of the disease which has gone outside the uterus. A similar retrospective study, I'm quoting these studies, and eventually another retrospective study. Now here he's highlighting the removal of more than 11 lymph nodes. So that also decides a lot on the overall prognosis of the patient. Now I do a lymphadenectomy for the sake of doing lymphadenectomy and say I've removed 4 or 5 lymph nodes. That doesn't make any sense. You have to do an adequate number of lymph node removal. So it, say 20 maybe pelvic or maybe more than 10 in parietic. If you have to do, then only that will make a change in the overall survival of a patient. Then there's this CPEL study which addressed the issue of whether you should do only pelvic or you do the parietic also. Because a lot of centers are doing only, say up to inferior mesenteric artery, they are not going up to the renal vessel. So it does make a difference. Like we have a data available from the Mayo Clinic. Now, when I was looking at this article, so I came across this lymph node ratio. What is a lymph node ratio? This ratio shows the burden of the nodal disease as well as the quality and the extent of surgical technique. Now, lymph node ratio, that is number of metastatic lymph nodes to the total number of lymph nodes removed. So if the lymph node ratio is 10, then overall survival is definitely 79. And if it is more than 50, it will definitely go down to 36. So it's interrelated to the technique you have applied and the and whether you have done the lymph node dissection or not. My slides are not moving. Okay. Now you have to do the risk stratification. Now, which patients would you like to leave without lymph node dissection? Because we know there are complications related to the lymph node dissection. But I just want to highlight a point here because there are a lot of oncologists who are listening to this. When we are doing a cancer surgery for cervical cancer, so that time we do not highlight so much on the complications due to the pelvic lymphadenectomy. But when we talk of doing a pelvic lymphadenectomy in an endometrial cancer, then a lot of emphasis is laid upon that, that this will cause a lot of lymphocysts and lymphedema and all. So I think if an experienced hands and a properly done surgery, definitely, and the training you have required, definitely will reduce the complications which we are so much scared of doing lymph node dissection. Now, for the sake of the time, I'll go to there are some systematic reviews which have been done for this issue. So this systematic review, which was done in 2016, they said that the current analysis provides evidence that the systematic leads to a higher overall survival rates. Removing more than 11 nodes, which I've already said, will definitely improve the overall survival rate. That several studies suggest that lymph node is more reliable than the surgery alone to determine whether endometrial cancer is metastasized and to reduce the risk of metastasis. Although several histological risk factors have been demonstrated to correlate closely, including tumor grade, depth of myometrium invasion, and the presence of 30 to 50% of serous or clear cell histology, lymphadenectomy remains the most direct way to assess and reduce the risk of metastasis. Now, the conclusion from this meta-analysis, which was in the 2016, is that the use of systematic lymph is in carefully selected patients may improve endometrial cancer staging, choice of adjuvant therapy, and prognosis prediction, which Dr. Umesh has also highlighted. Now, another meta-analysis done in 2018 says that paraortic and pelvic lymph node dissection associated with favorable survival outcomes in endometrial cancer patients with intermediate or high risk. But this intermediate or high risk is also part of the early stage endometrial cancer. So further large-scale randomized clinical trials are required to validate the findings because they are saying that paraortic also has to be done. Now, NEJA is part of this evidence review, which was published in 2019 by ICMR. So the ICMR, which has given guidelines for our own country, the extent of lymphedema is important to decide the need to administer adjuvant therapy, but may also impart to the therapeutic benefit, though still it is debated. We know there's a debate. I think for the last 20 years, we are debating it. I must have taken part in at least 6 debates on the same topic. So in order to determine the patient with a low risk of nodal metastasis in whom lymphadenectomy can be safely omitted, several risk stratification systems have been developed. I think we should be all working on this so that we can make some models which have been proposed by Mayo Clinic model in 2000. And then a Korean GOG group has also given a model. The risk of nodal disease was 1.7% in thus identified low risk women. So they have identified the low risk. How they have identified? They have done the assessment of myometrial invasion. Then they have done serum CA125 and other factors clubbed together. So you have to make these models so that you can identify actually the low risk patient among this early stage where you can omit lymph node dissection. Then the ICMR, the guidelines which are meant for our low resource setting continue that only 10% of women with lymph node metastasis will have enlarged nodes and may be missed on direct palpation through the overlying peritoneum. So we cannot rely on that. The incidence of paraortic lymph node positivity in cases where lymph node nodes are positive is 50% and approximately 2% if pelvic nodes are negative in well-differentiated cases. So in women having endometrial cancer with high-risk features, where the myometrial invasion is more than 50%, or it's a grade 3 disease, and histology of serous, clear cell, or carcinosarcoma, or complete systematic lymphadenectomy up to the level of renal vessel is recommended. And this is the reference which they have quoted for this. So, so ICMR, what does it say for the poor resource? The resource poor settings, that is all of us, with less than adequate infrastructure and technical issues, the lymph node dissection strategy needs to be individualized. You cannot copy all the guidelines from the West. When the tumor grade and the myometrium invasion are not likely to be ascertained fairly, accurately, pelvic node dissection should be done so that unnecessarily pelvic radiotherapy, which would increase both the cost and the morbidity, is not administered. So I think this is the take-home message from my side, because for us, we do not get all, like if you are working in a government setup, we do not get all the facilities for a patient. So if you are working with the limited resources, so I think doing a lymph node dissection by an experienced surgeon meticulously will definitely not add to the morbidity. But of course, we had a lecture on MIS. So where you have a morbid morbidities associated like obesity, you can always resort to MIS, or the best for that patient would be to go for robotics to avoid the complication. And I'm sure Nirja is going to talk on Aztec and Italian trial. I will only say what was the criticism. So we have got more than 11 trials retrospective which are showing the benefit of lymph node dissection, but there are only 2 prospective randomized trials, but there has been a lot of criticism regarding these trials. They have been criticized due to the non-compliance with regard to the lymph node dissection, as well as the small average number of lymph nodes removed, and more patients of low risk category they have included. In addition, some patients are randomized to post-operative radiation irrespective of surgical pathology, which have skewed the survival data. And in Italian study, this study did not have standard criteria for use of post-operative adjuvant therapy and did not consider recurrence risk in the survival, in the analysis of the survival. So my concluding slide is, by our ESMO, ESTRO consensus conference, which was held in 2016. So they have given a guideline. I think all of us should follow that. Lymph node dissection is a staging procedure. So we cannot say that we are doing cancer surgery, but we should not do surgical staging. Lymph node dissection is not recommended for low risk patients, provided you prove it is a low risk patient. There are only 2 negative trials. Intermediate risk data conflicting. Lymph node dissection can be considered for staging purposes, but in high risk group, we have to do it. Retrospective studies have suggested that lymph node dissection might lead to survival benefit. I think I rest my debate with this slide. Thank you.
Thank you, ma'am. Points well discussed. Now let's see what Nirja madam has to say her contrary views.
Thank you very much. And while my screen is coming on, I will say thank you to the organizers for including this as we come to the end of a fantastic masterclass over the last 2 days. And thank you very much to Dr. Zuchi for setting the stage so nicely. I think Dr. Zuchi's screen is still there. If you can just exit it.
Okay.
And I completely agree with Vijay. We have been going to Agoy for so many years, and I think if you see the program of 20 years ago, you will see in that also the debate. You know, the Shaw's book said, what do the surgeons and radiotherapists argue about except whether to treat cancer cervix by surgery or radiotherapy? But I think also this what to do. So I will say that I hope that in the next 8 minutes, I will be able to bring clarity to this subject for you. And I already see Dr. Vijay partly has conceded it by saying already where you can say avoid the dissection. So let us see what there is in this respect. Next. And already it has been pointed out that when you talk about lymphadenectomy for endometrium, you are not talking just the one pelvic nodes, but also the other routes which are taking directly to the para-aortic are equally important. And here I would like to draw your attention to this results from the FIRES trial, which also show you not only the various sites at which the positive nodes were the sentinel nodes. But also please do not forget that there are rare sites like the presacrals, the left presacral, the right presacral, very easy to miss even after you have done what you think is a very good lymphadenectomy and you have removed the 20 nodes they wanted and the 10 up front, and still you could miss these in a total lymphadenectomy as well. And what you must also see is that it is above the IMA that you will get, so you have to go all the way up. Next slide, please. And so, as has been said, are we looking at staging or are we looking at the therapeutic purpose? Now, if we talk of staging, then the likelihood of nodal metastasis in stage 1 endometrial carcinoma in pelvic lymph node mets is less than 1 to 10%, and para-aortic is less than 5%. If we are talking of endometrioid, it is 0.9%. If we are talking of serous, it is 2.5%. We must decide whether we are going to do this extensive procedure in 100% of cases to give benefit to these small numbers. And the more vigorous we are and the more nodes we remove, the more the risk that these patients are going to come back with problems which will be quality of life issues for the rest of their lives. So we must look at these probabilities. And so it is not a one steady stream of light. You have to look at the prism that breaks it up into the high, intermediate, and the low risk. It's definitely not a single entity. It's a heterogeneous group with variable risk and prognosis. Dr. Mahant Shetty has alluded already to the very distinct molecular profiles that are now being looked at. But I'm not going to go down that route, which is something which is not accessible to the vast majority, but just to talk about simple features which anybody's pathologist is competent to tell us about. Next slide, please. And again, if we see the numbers, but we know that half of them, more than half of them are definitely in the low risk group, and about a third of them are in the intermediate and high risk group. And it is a small proportion, fortunately, in C endometrium who come advanced. Next slide, please. And the burden of nodes was worked out in early stage cancers, and it was very clear that if they are endometrioid grades 1 and 2, less than 50% invasion, tumor size is up to 2 centimeters, the probability of positive lymph nodes or lymph node recurrence is less than 1%. Next, please. And if we look at this study, which came out of the Mayo Clinic group, we can see very clearly that depending upon the size of the tumor, less than 2 centimeters, 0 lymph node involvement, more than 2, 7%, grade 1, 4%, grade 2, 7%. No patient in the low risk group had nodal metastasis, and the rest of them, of course, we know are coming in the high risk group. Next slide, please. So then we look at the therapeutic role of lymphadenectomy in early endometrial cancer. Next. And this is the Italian study which has been alluded already by my dear friend, Dr. Zucchi. And yes, it is important to see the randomized, because looking at retrospective, small numbers of studies, this is definitely way better than that. It is a prospective randomized clinical trial which has shown that there is no significant differences in the two groups for disease-free survival and overall survival. And this is really our bottom line in oncology. There are only two things we worry about: the survival and the quality of life. And if the survival is fine, it is fine. And this is what we see in the Aztec trial also, which has been spoken about. And the randomization to the standard surgery versus the lymphadenectomy group. If we just look at that data and we discount all the other problems that were mentioned by Dr. Zucchi, and we see that there is really no difference in the survival, the overall survival, the death rates, which are in the standard versus the lymphadenectomy groups, and the recurrence-free survival as well has no significant differences. So pelvic lymphadenectomy cannot be recommended as a routine procedure for therapeutic purposes outside of clinical trials, I think we are all agreed. Next slide, please. This is again that just showing the forest plot regarding the efficacy, and you see that the overall survival, it definitely favors this standard treatment. The recurrence-free survival as well. By standard treatment, we mean the hysterectomy, bilateral salpingo-oophorectomy. Next slide, please. And this was a wonderful analysis of the SEER data, 12,000 plus patients, which was looked at. So obviously, like any SEER analysis, it is retrospective, but very powerful numbers, and clearly shows that for the low risk, there is definitely no difference. Even in the intermediate risk, the difference does begin to come, but not as marked as it is when we go into the stage 3C4 kind of nodal disease. Next slide, please. And then there was the Cochrane review, which was basically based on these two studies, primarily for want of any better studies, which has showed the same thing, no difference in OS and recurrence-free survival. Next slide. And the Sept, which was spoken about, looking at the survival effect of para-aortic lymphadenectomy in endometrial cancer, again, a retrospective cohort study. And these were two nearby hospitals in Japan where one center was routinely doing the studies and one center was not. So it's retrospective, it's got different surgeons with different skills. The cancer registries from two hospitals, one has one philosophy, the other has another. The para-aortic lymph node group was much younger, 40-year-olds on a median, and had a far higher proportion of women who received adjuvant chemotherapy. So none of the trials is really beyond sort of problems. Next, please. And then we have talked about whether it matters or not that they get lymphedema or lymphocysts. And I think everybody who has had these patients knows that they forget the cancer, but they never forget their bad quality of life. And not only that there are more of those complications, the median operating time is longer, and for various reasons, the outcomes are affected. Next slide, please. And then the kind of vertical rather than the horizontal incision, even if you're going the abdominal route, the ileus, DVT, major wound dehiscence, we've talked about other things. Next slide. And advancements in imaging are definitely significant and getting better all the time. Next slide. And if we can identify the women who would benefit from a standard, and we've had this talk about the MIS and how well it does for many of these younger patients. And please note in this list that even though the number of patients who had the pelvic or para-aortic dissection was more in the ones who had abdominal hysterectomies versus laparoscopic hysterectomies, even then, if we looked at the outcomes, next slide, please, there was no difference in the cumulative incidence of endometrial cancer recurrence, new cancers, or deaths, even when the lymph node attention had been very significantly different, which again reinforces that it is beneficial in many ways to consider who gets it. And NCCN has laid down these guidelines once again very clearly: less than 50% MI, less than 2 centimeter size of tumor, well or moderately differentiated histology. And the final pathology could change from your endometrial biopsy. We know that. Having said that, we can always even think about secondary procedures to complete when required. Next slide, please. Especially if we've gone in by laparoscopy the first time. And the ESMO, ESGO, ESTRO looked at the diagnosis, treatment, and follow-up of the endometrial cancers, and again looked at this evidence to say that lymphadenectomy is not recommended for the low-risk endometrial cancers. You could consider it for the intermediate risk cancers, but data have not shown a survival benefit. Next slide, please. And the SGO, again, likewise, has the same recommendation. Next, please. So in conclusion, I will say that lymphadenectomy cannot be recommended for all early stage endometrial cancers. There is no survival benefit as evidenced by the 2 RCTs we have presently even for the intermediate grade. Increased risk of morbidity is without a doubt. And going forward, the sentinel node biopsy may represent a viable compromise in this groups of patients. Thank you very much for your attention.
Thank you, ma'am. Thank you for giving your views. Dr. Zusti, you have 2 minutes for rebuttal.
That was a nice presentation. That's why I didn't go into detail of these trials, because I know Nirja has those 2 weapons. So let me not touch upon them. So you see, the topic was early stage cancer. So I have already said in my presentation that the patient, the safety of the patient is first, but then that should not be compromised as far as the definitive surgical management of the patient is done. So when we are all saying that for endometrial cancer, it has to be surgico-pathological staging. So then for early stage cancers, I'm again repeating, I'm not talking about the low risk, early stage cancer, when we say stage 1 and stage 2, that lymph node dissection is done in every patient. Even Nirja is saying that it's only a small group of patients which are low risk. And to identify that small group of patients which is low risk with a 2 centimeter growth and less than 50% endometrium, confined to less than 50% myometrial invasion, and you know, it's not very easy to diagnose. How much you rely on a frozen section, 30% that can be false. Then we have known that 30 to 40% it can get upgraded. So I don't think it is a good idea to do a re-surgery for a patient. As I am emphasizing, the patient safety is first. So by doing a lymphadenectomy in early stage cancer, besides then the low risk patients, I think I'll still go by it. Now, whether to do paraiotic and how much to rely on, because the paraiotic is the one which is going to increase the morbidity. Definitely it is going to increase the morbidity, we know it. Then as Nirja has pointed out that we have got such wonderful imaging techniques, so we can rely on those imaging techniques there. And there are people who are practicing oncology and they are only doing up to the inferior mesenteric artery. All the Mayo Clinic or whatever publications we have, they are all very, very clear that whenever the recurrence comes, it comes in the retroperitoneum in that area. So you have to go up to the renal vessels. So when we are wanting to give her, say, progression-free survival or disease-specific survival, then we have to do a systematic surgical pathological staging. That is my reply to Nirja.
Nice debate, interesting debate. Actually, lymph nodal dissection in early stage endometrial cancer has been a controversial topic, as Madam said earlier, since many years. As we are advancing in the treatment modalities and as we are giving more tailored options like stage 3 endometrial cancer, PORTAC3 has shown evidence that CT-RT acts better. So we don't want to miss on these patients also, those 10 to 15% of the patients also we don't want to miss. So maybe that sentinel lymph node biopsy, as we master the art of doing it and start identifying bilateral sentinel lymph nodes in more and more number of patients, sentinel lymph node biopsy is going to give us a middle way so as to reduce the morbidity as well as to adequately stage our endometrial cancer patients. So,
I think because we had only 8 minutes, so we could not have covered sentinel node also. Otherwise, that is the way forward now.
Yes.
So we had to confine to our 8 minutes.
Yeah.
So we'll move forward. Over to you, Dr. Chandan.
So I just wanted to say that in the debates that we have in the hall, we can have the audience to put up their hands and take their comments, and we are missing that over here. Maybe we should have planned for the voting from the audience.
So now from next time we will take care.
But virtual has an advantage that anytime, day, night, you sit and discuss. That's an advantage. There is no hurry to go home.
Very right, very right.
That's the biggest advantage of virtual.
Thank
A lot
you
of
so
people
much.
can stay and stick around rather than वहाँ पर तो lunch time, tea time पे बाहर निकल जाते हैं लोग. तो यहाँ पर सारे लगे हैं आपके उसके साथ.
Sure, ma'am. So, Dr. Chandan has some internet problems, so he will be joining in some time. So, thanks a lot, Dr. Vijay and Dr. Nirja, for such a wonderful debate. We will now move over to next session. It is a debate, and for debate, I will invite Dr. Shyam Agarwal. Sir is a director at the Department of Medical Oncology, Sir Gangaram Hospital. Over to you,
So
sir.
this is a panel discussion.
Yes, this is a panel discussion.
Yeah.
Thanks, Dr. Gautam, and then good evening, everyone. I think we had a wonderful session on early endometrial cancer in terms of the debate preceded by the talk. So I think we have, I believe, 7 panelists, Dr. V. Kanan, Dr. Jaya Ghosh, Dr. Rupinder Sekho. Madam, you're there, Dr. Sekho?
Yes, I'm there.
Okay, Dr. Gaurav Gupta, Dr. Prashanth, Dr. Sunandan, and Dr. Sajal. So good evening to everybody.
Yes, sir, I'm there. Good evening.
So let us put things into perspective by having a panel discussion on how to go for adjuvant therapy of early. In fact, the topic is stage 1 endometrial cancer. So can I have my first slide, please? Okay, so I've just put it as early stage, but I think most of the slides I've made are on stage 1. So before we go on to the, we've designed a few cases to thrash out what should be the best line of treatment for stage 1 or early stage endometrial cancer. So before we go on to that, I think these topics have been discussed, but just to revise them, next slide, please. So what are the factors that determine relapse in a patient with early uterine cancer? So I think we can have Dr. Rupinder Sekho to answer this, and we are focusing on really stage 1 uterine cancer. So what do you think are those factors which we should keep in mind for determining the relapse rate? Dr. Sekho, please. Can you hear me, Dr. Rupinder? Can you unmute yourself?
Yeah, I've unmuted myself. I had unmuted, but I think it just got muted again. Can you hear me, Dr. Shah?
Yeah, we can. Yes, ma'am.
Okay. So I think we've had a wonderful evening before, and everything has been thrashed out. But just for the sake of the panel discussion, I'll just enumerate what are the factors. One, of course, is the age of the patient, which is very important. The grade of the tumor is very important. Size of tumor is no longer considered that important. Myometrial invasion, whether 50% or otherwise, is important. Then, of course, LVSI, the lymphovascular space invasion, the histology. What is the histology of the tumor? The morphology of the tumor is important. And so also are the molecular markers, but not many of us have access to that. And then, of course, whether there is lower uterine segment involvement, that is whether there's, and if there is any cervical involvement. So these are a few of the important factors which you have to club with deciding what exactly do you want to do with even an early stage uterine cancer, endometrial cancer.
Perfect. I think you have actually covered all the points. Anybody, Dr. Prashanth or Dr. Sunandan, they want to add any point here as to those factors which could be critical in defining the adjuvant therapy in a patient with stage 1 or early uterine cancer? Dr. Prashanth?
Nothing, I mean, more than this, nothing much. I think one, Madam has already elaborated on the different factors. I think it's probably the other thing could be the extent of lymph node involvement. The lymph node involvement is another important prognostic factor. I think it's very, very important in it drops down the survival by around more than 50%. So I consider that as one of the most important factors which can actually have and determine the survival and even the relapse among patients with.
Okay, great. So is Dr. Sunandan there? Would like to add any more point here? Can you show the next slide, please, in the meantime? Yeah. So I think these are the points which have been said. I can show you a few slides depicting the relapse rates. Next, please, or the degree of involvement on the nodes. So you can see here. So if it is grade 1 versus grade 3, or if there is myometrial invasion, none versus deep. So it jumps from positive pelvic nodes 3 to 18% and 1% to 25%, and similarly the para-aortic nodes. So the grading of the tumor is so very critical here, and so is the depth of myometrial involvement. Next, please. So this is combining the grade and the myometrial invasion. So if it is grade 1 and there is no invasion, 0% to 34% if you have grade 3 and deep invasion. That is the pelvic nodes, and similarly the para-aortic nodes. So these two factors of grading of the tumor and the depth of myometrial invasion extremely critical. Next, please. And the tumor size, although Dr. Rupendra says is not important these days, but then these are the data from the earlier studies which have been done. Next, please. So this is again another study showing you the entire surface. Any comments, Dr. Kannan or Dr. Sajal, on this point on the tumor size?
No, it is going well, but now presently as of today, it is not much entertained.
Okay.
It isn't, I quite agree with this. It isn't much entertained, though one wonders why. Because like Dr. Sham has shown the study, there are some, whether it is a polypoidal tumor, and when our pathologists give us the report, they do tell us that there is so much of, tumor-free surface still there. And that is definitely significant, though we don't really have any study to support this, that what if the tumor is just a small polyp or just a small surface area, or any percentage of the surface area of the endometrium is covered. So, I mean, we just have to go with the evidence which we have before us, which doesn't really include the tumor size. Because you can see over here, there is the depth of invasion when there's entire surface area, the whole of the surface area of the endometrium is involved, and then when the tumor size is less than 2 centimeters, and so on and so forth.
Right. So, I mean, these studies are there, but I think as Dr. Kannan said that there is perhaps, so can we go to the next slide? I think we can go to the next slide, please. So I think this point was made, the role of the capillary space involvement, the isthmus and the cervix involvement, which are critical again for the positive nodes if it is involved or if it is not involved. Next, please. So let's go on to some of the cases which we have, tailor-made to study the, So this is another important issue. Dr. Kannan, would you like to make a comment here on the...
Yes, doctor. Thank you. Age more than 60 as far as the POTEC is concerned, but age more than 50 as far as the GOG 249 is concerned. So there is a little bit of a question on that. Depth of invasion more than 50%, yes. Grade of tumor, any grade 2 to 3. It is a problem as far as the 2 is concerned. Sometimes it is put as 1 and 2 in a low risk factor. It is put as 2 and 3 in a high risk factor. So the grade of the tumor is not very clear in any of the studies. LBSI, very important. Thank you.
Okay.
Can I just add one point over here?
Yeah, Dr. Rupendra, please.
I so agree with Dr. Kannan that grading is important, but still the most gray zone of all things. Grade 2, I have always considered is basically a pathologist grade, where they cannot decide whether it's really a high risk, a grade 3 or a grade 1. So, one should be very careful when you're looking at, when you're taking only a grade 2 tumor.
Okay, Dr. Neerja has made a point in the chat box where she says, in many of these, this is regarding the tumor size, in many of these women, the tumor size is really large, but superficial, and the sentinel node are -2. So the size perhaps doesn't have much importance if it is superficial. So that's what she tends to say, I think, in this particular, chat here. Okay, so let's go on to the next slide. So this is a patient, endometrioid carcinoma of the uterus, grade 2, stage 1A, so which is less than 50%. and there is LVSI. So age is 65 years. So Dr. Sajal, please. So Dr. Sajal is the radiation oncologist, right?
Sir, yes, sir.
Yes,
so
sir.
a very good evening to everybody. So this is a 65-year-old lady with 1A grade 2 and LVSI is positive. So basically I would offer her radiotherapy, but probably it would be vaginal brachytherapy, which would be preferable as she is above 60 years of age and LVSI is positive. One more important thing I want to ask is whether she had been surgically staged adequately or not. Because once she is LVSI...
Yeah, yes, properly surgically staged, lymphadenectomy.
Yeah, so properly staged, lymphadenectomy done, node negative. So probably vaginal brachytherapy only would be offered to her.
Dr. Kannan, you agree?
Yes, I do agree in one point. A perfectly staged, a grade 2 LVSI, 2 risk factors. With these 2 risk factors, age above 50, as far as the GOG 249, they say better err on the pelvic artery. As far as the Portex says, better err on the vaginal brachytherapy. So both are right.
NCCN also says for such a case that we should give just vaginal brachytherapy.
Dr. Prasant, you want to make any comment? So I do see a little debate here. Dr. Kakkar says only vaginal, but then Dr. Kannan says it's not wrong.
Hey, sorry, that is also right. But I say, as for the GOG 249 study, that is a concern. They say that any patient above 50 with 2 risk factors, there are 2 risk factors, grade 2. We are talking about the grade, no, this is the problem. Grade 2 and 3 is one risk factor. LVSI is another risk factor. So we got 2 risk factors. They say it becomes a higher intermediate risk group. In this group, either VB, vaginal brachy, or pelvic artery. Here run the more aggressive treatment. That's what they put it.
Right, the patient is one. The problem is that the patient is one. And if he goes to 2 different radiation oncologists, you know, so he or she, I mean, she's going to be awkward. So there is a debate right here.
Yes, Dr. Kannan is very right. As far as GOG 249 goes, this is the with 2 risk factors in 50 to 70, EBRT is an option here. But if we see patient is 1A grade 2 and LVSI, though, see, positive LVSI means higher chances of nodal recurrences. Once a node surgically adequately staged node has been taken care of, I think there is higher chances of local recurrence as compared to pelvic nodal recurrence in this situation. So prefer vaginal brachytherapy as compared to EBRT, which is going to be obviously toxic and probably would be an over-treatment, maybe an over-treatment in this scenario.
That's what generally they prefer. They want an over-treatment rather than an under-treatment. Prefer of the more aggressive one of the 2. Now, what I'm saying is that both are right. Now, I don't say this is wrong and that is wrong, but there are 2 options available.
No, but doctor, if I might ask, who prefers the more aggressive treatment, the patient or the doctor?
No, it is we, the oncologist, make a decision telling to the patient which is appropriate.
I don't.
So, you know,
patient will not decide.
Can we go to the next slide?
Yeah.
This is unending. So that's why I put this scenario here.
Yes.
So we have 2 of the radiation oncologists who have, you know, a differing point of view, and they are saying that both are perhaps correct.
I think, sir, we have Dr. Umesh also in the audience, so we can take his valuable suggestions also. What he will suggest.
Dr. Neerja, if she's there, I mean, she's always also open. Dr. Umesh, are you there? Can you make a comment?
Yes, I think you're right in saying that both radiation oncologists are correct in their approach, for the simple reason that I would say LVSI positive is a risk factor. Definitely this patient merits post-operative adjuvant therapy. And Sajal's point is right that if surgeon has operated well and all nodes have been dissected, the yield of nodes is good, then there is an option to give vaginal brachy alone. Whereas Dr. Kannan, if he feels that general gynecologist has done lymph node sampling and only few nodes have been dissected, such patients should offer external beam radiation therapy. And the reason why I'm telling this is not all gyne-oncologists do the pelvic clearances well compared to, let's say, tertiary centers. So this has to be customized a bit. But what is important is adjuvant radiotherapy is vital.
Yeah, we see your comment on the chat box. That nobody is debating that this patient does not need the radiation. but the issue is the type of radiation is being debated. Okay, it looks like can we have the next slide? So this is, what they were saying, that consider vaginal brachytherapy if lymphovascular space invasion is there or the age is more than 60 years. So which in this patient, this is the NCCN guideline, but I think we have debated that. So can we go to the next slide? So this is, grade 2 here, stage 1B, and no LVSI, and the age is 65 years. So, Dr. Kannan, please.
Only vaginal brachytherapy.
Okay, Dr. Sajal.
Yeah, I concur with sir. Only vaginal brachytherapy. As its age is more than 60, 1B, no LVSI, so brachytherapy alone.
We agree. Thanks.
Yeah.
So Dr. Rupinder, you are happy with the radiation oncologist?
Yes, yes. I'm always happy with them, sir.
Yeah, because the ball is in their court. Once the proper surgery has been done, the choice is. Dr. Prasant, any comments?
No comments, sir. I completely agree. I think there is no controversy in this, unlike the previous case. I think we wanted to make it more challenging for the radiation oncologists and debate during the panel. So I think the first scenario, but second scenario, no debate, sir.
Okay.
I'm a surgeon, so after a complete surgery, I would completely rely on my colleagues to get the best.
Sure. So can we go to the next slide? So I think this is about I will not go into this. This is basically POTEC 2 comparing pelvic and vaginal brachytherapy. Next, please. Next, I think we'll skip these slides in the end. Everybody's aware of them. Next, please. So although in the brachy, there was a higher incidence of pelvic recurrence, but then possibly the pelvic dissection or the nodal dissection will take care of that. So these are the risk factors for HIR, which we've already discussed. Next, please. So this is the third case. I think this is the same. Only thing is the age is 72 years. Does that make a difference, Dr. Sajal?
Sir, if we follow GOG 249, so it says age more than 70, we need only one high risk factor to decide the treatment, whether EBRT should be given. But if we see this scenario, again, I think as like the previous case, I think I would go with vaginal brachytherapy only, because there is no LVSI adequately lymph node dissection done. So only brachytherapy.
Okay, I think Dr. Kannan is going to agree with this, right?
No, sir. Age is 72, one big risk. 1B, another big risk. Grade 2, another big risk. So better to err on the external RT rather than only brachytherapy. Again, they are different.
Wow.
But
So,
72...
this is interesting. Yeah, Dr. Sajal, you want to rebut? Well, that's what the idea of bringing these cases, I mean, I think not uncommon scenarios. I think these are there in day-to-day practice today.
So my initial submission was, as far as GOG 249 goes, I think EBRT is the answer. But I would prefer brachytherapy because see, age is again 72. Chances of recurrences are higher. That is local recurrences. So, and POTEC 2 has already shown EBRT versus brachytherapy. As far as vaginal control rates are concerned, both are similar. Toxicity and quality of life obviously will matter more if we give EBRT. So I would err on brachytherapy side.
Dr. Rupinder or Dr. Prasant, any comments? I think we'll go to the.
I think I will agree with Dr. Kannan that this patient definitely we should give EBRT as well as brachy.
So I think those risk factors where age is also an important issue should be kept in mind, along with the depth of invasion and the grade of the tumor. And I think as we discuss those issues.
Yeah, risk stratification means that only. I mean, let us follow a guideline, and even NCCN says the same. So does
next slide, please.
Ma'am, just to, if you see the ISMO guidelines, LVSI is negative, so adequately staged, only vaginal brachytherapy. So guidelines also differ a lot, ma'am.
Yes.
I agree with you. They differ a lot. In fact, it's unfortunate that we don't have any fixed guidelines, and we are always quoting others. But then that's how it is.
Next slide, please. So can we have the next slide?
I think this is the one.
Yeah, this is the one. In the previous slide, LVSI was negative, and in this it is positive.
We have all,
there Dr. Sajal will agree that we go for EBRT.
EBRT, yes. I don't think there will be a question in this.
All the factors are, not good. Age and the depth of invasion and the LVSI. Dr. Sajal?
Yes, sir. We will prefer EBRT in this case as LVSI is also positive.
Okay. Is there another slide, please? Next. I think these are the other factors. So age, 70 years is another risk factor. That was the point to be highlighted here. Next, please. Next. Okay, so this is grade 3 now. And I want to bring in the chemo doctors here. So as regards radiation, I think that needs to be done, right, Dr. Kannan?
Sir, this, if you ask me, this is typical POTAC 3 says that chemo RT in an age above 70 is definitely superior. Let the chemotherapist take an opinion.
Yeah, Dr. Gaurav, are you there? Or Dr. Jaya is there, please?
Yeah, I'm there. Good evening, all. So I would just say that age is more than 70, but if you look at the histopathology, it's an endometrioid cancer. So
Yes.
it's an early stage endometrioid cancer where, the endometrioid variety really in stage 1 did not benefit. So it is only the serous subtype which had a benefit of adjuvant chemotherapy, CTRT. And of course, if you want to do a further molecular subtype, one can do a P53 on this, but you see most of these P53 are of the serous subtype. Of course, some of these endometrioid may also have P53 mutation, but it is radiation alone for the 72-year-old with a grade 2 endometrioid cancer.
Grade 3.
Grade 3. I would agree with Dr.
Grade
Jaya on
3,
this.
but the subtype is endometrioid.
Right. So, Dr. Rupinder.
Yeah, same. I quite concur what Jaya has said. The very fact that it's endometrioid, no, local therapy is okay. EBRT is fine. Only radiation is required. I don't think we need to give chemotherapy to her.
So can we go to the idea of showing this, can I show the next slide? So can we go to the next, yeah? So these are the inclusion criteria where they had stage 1B and grade 3. So that was the kind of tumor along with LVSI in this patient whom I had shown. So they included such patients and these were all histologically confirmed endometrial carcinoma. And of course, those were the patients who were included in this.
Yes, they were included, but the subgroup analysis did not show benefit in the endometrioid variety.
We'll see the forest plot. Jaya, can you go to the next slide? Next slide. Next slide. Next, please. Next. So that's go to the previous one. So this is FIGO stage 1 and 2 and stage 3, right? So this is favoring chemoradiation as far as this is concerned.
No, if you look at the forest plot, the confidence interval are widely
right, but that's a subset analysis, right? So that is the debate here, So this is a hypothesis generating thing. So how keen are you on giving chemotherapy in what is your threshold, to go for chemo? That is the issue.
See, we have a grade 3 tumor. It is positive for a CTRT. We have age greater than 70, significantly positive, and we have a grade 3. So looking at all these factors, yes, I really ask my medical oncologist, please do chemotherapy.
No, sir, I would disagree with you here.
Okay.
I would, so in this patient, 72-year-old endometrioid, early stage, I would urge for RT alone because, really, and we are looking now more at biology of the tumor. So for this patient, I think early stage, this kind of tumor is probably RT alone. Now, if she is P53 mutated, you tell me, and she's a fit 72-year-old with normal GFR, then that is something that I might consider based on the molecular classification. But otherwise, for an endometrioid, subtype early stage, no chemotherapy. It's only the
But the
stage
forest
which.
plot doesn't say that. Forest plot said chemoradiation.
Sir, if we
But
see,
forest plot has wide confidence intervals and
No, that
subgroups.
is different. You only mentioned about forest plot. It shows that.
but sir, if we see
Yeah,
that,
so what is your threshold in endometrioid uterine cancer for using chemo?
So it's only in stage 3 that we give
sir,
chemotherapy.
because the updated POTEC 3 has shown the benefit
Yes.
only in stage 3,
Yes.
as well as serous or other high risk varieties, histological variants.
I also agree with Dr. Jaya because the driving force in the POTEC 3 result was stage 3 patients and not the stage 1 and stage 2 as our patient is. So despite having high risk features, I would not offer chemotherapy to this patient.
So generally in the adjuvant setting, we offer chemotherapy to patients who are either stage 3 or if they are stage 1 and stage 2, but they are serous subtype.
Yes.
Dr. Rupinder, what are your thoughts?
Can I add here one statement?
Yeah,
Yeah, you're right in stage 1, stage 2 for type 2 histology, but again, for stage 1 serous, there is no much convincing evidence for chemo. It's just that by virtue of type 2, we tend to give chemo, but there's no evidence for type 2, stage 1. Stage 2
Yeah,
onward,
yes, but if you see serous and many other times they have P53 mutation, and if the patient is not, of course, 72, but a younger fit patient, probably we would err on the side of giving chemo radiation to that patient present. Although these are subgroup analysis, but
Yes,
given the present scenario and the present updated data and the molecular analysis.
yes, I agree, Jaya, but these are all hypothesis generating studies which will come in future. P53 mutation in serous, what would be the treatment of choice? So that would be what would be looking at in future.
That's all right, Dr. Mahan Shetty. See, the thing is, P53 is something which is easily available to all of us. So we all tend to rely a lot on the P53 mutation. And like what Jaya is saying, if there is a P53 mutation, even for an endometrioid, and of course, like she said, if the patient is fit, we would definitely err towards giving her chemotherapy. But if it is not P53 mutated, even if it is a grade 3 endometrioid, I don't think we need to really give her chemotherapy.
Yeah,
So
for this patient, age 73, madam.
No, you want to give her chemotherapy because she's 73? Is age
No.
the only factor?
In fact, the POTEC says age should not be a bar. Do not get worried about age above 70. Because they say it is
the age, sir, in Holland, 73 is like 50 in India, sir.
What we can say is the data available.
73 in Dutch people.
That's not in our country also, I think we are fast approaching that. But then still, as of now.
So as now, endometrioid P53 mutation, yes, we may think of, but we really are all looking into subgroup analysis, but that is something that we are thinking, yes.
And in fact, if I might digress, for an endometrioid stage 1C also of the ovary, there are many medical oncologists who would not like to give adjuvant chemotherapy.
So stage 1C high grade endometrioid, we would definitely give chemo, but not give them full paclicarbo, because if you look at the GOG 157, it is the high grade serous variety which really benefits from the 6 cycles of paclicarbo. So either 3 paclicarbo or single agent carboplatin maybe.
That's what.
So Dr. Sunandan is also there. Can he make a comment? Your thoughts on this kind of issue, Dr. Sunandan?
Yes, sir.
So are you happy getting your patients chemotherapy in this scenario?
What in 72 radiation as well as chemo, because radiation and adding chemo to that adds a lot of morbidity to the patient. And it's not stage 3, right? Because I missed the initial slide, so I'm sorry I missed that.
Okay, so I think there is a little debate here on the use of chemo in this scenario. Although most medical oncologists may not want to use chemotherapy, at least in stage 1, but then if it is stage 2 and beyond and the high risk factors are there, then And P53, for example, if it is mutated, well, then that takes the case towards chemotherapy. Right, Jaya?
I think Dr. Sham, all the medical oncologists says no. The only radiation oncologist says possibly is chemotherapy. We'll follow the medical oncologist's opinion. That will be better then.
Yes, sir. So I think for 72-year-old, and I think Gautam has also asked how many 72-year-olds are we able to give the full POTEC 3, and I agree with him that, of course, barring some of the few fit ones, even for, we struggle to give CTRT to some of these patients who are, borderline GFR.
No. You look at breast cancer, I think 75 plus are getting chemotherapy in the adjuvant setting today. So let us not make that argument that 70 is not fit for chemotherapy.
No, I'm not saying 70 fit for chemo is not fit for chemo. We'll have to look at the complete profile. It's not only the age, you look at the comorbidities, you look at the GFR. And at 72, I would like to say that, the GFR that we calculate, so the calculated GFR may not be the actual GFR. And, so sometimes with age, and especially if they are like some of our population may be thin built and low albumin, these kind of patients, the GFR calculation by the Cockcroft-Gault method may be fallacious, and that's one of the limitations of these GFR calculations. So, I mean, that's just another point I wanted to highlight for these elderly patients.
Moreover,
Dr. Shah, for the sake of argument, a breast cancer, 72-year-old breast cancer patient would be definitely more fit than endometrial cancer.
Yes.
Yes. So can I make a comment?
After surgery and radiation therapy, the condition of the patient might not be that good as in the breast patient.
Yes.
And also, I would just like to...
Jaya?
Yes,
Jaya?
sir.
So what is the sequencing if you have to choose to give both?
So generally what we follow here is I mean, this is what we had been doing before even the POTEC 3, so we usually give them paclitaxel and carboplatin and follow that up with CTRT. The main reason being, the delivery of chemo after CTRT becomes difficult. And of course, now we have the GOG also saying that RT is not needed, but of course, there are debates, at least in advanced stage endometrial cancer, stage 3. So when we do use chemo, we give them the reverse sequence, that pacli-carbo followed by RT or CTRT, depending on the tolerance.
We also follow similarly.
POTEC gives chemo RT first, followed by 4 cycles of chemo, right?
Yes. But, for sometimes when we have needed to give them chemo after RT, generally we delivering the chemotherapy and having neutropenias and sepsis, that is the problem with giving.
So, Dr. Kannan, is it acceptable?
Yes, exactly. We follow the same way like Dr. Jaya was telling. We first give chemo followed by RT. In the cases where we decide both are needed.
Dr. Sajal, you agree?
So we also do the opposite way. We give chemotherapy first and followed by chemo radiation.
But there are a lot of radiation oncologists who don't like us giving chemotherapy first. They want to give the radiation first and followed by chemo. Dr. Rupinder, what is your experience in the Rajiv Gandhi?
Same. We give chemotherapy first, followed by CTRT or RT, whatever is the requirement.
I have seen the wrath of the radiation oncologists, after we refer them for radiation after the completion of the chemotherapy. So I faced it once or twice from certain institutions. I'll not name, obviously. Dr. Prashant? Is he there, Dr. Prashant or Dr. Sunandan?
Yes, sir.
Any comments on the sequencing of the radiation and chemo in patients who have to take both?
So we would prefer chemo first, followed by radiation.
Okay, there seems to be some consensus there.
Yes. There is a consensus.
So can we move on? I think we've had a reasonable discussion on this. So, okay, now this is another important point for the surgeons, I guess. I think if you get a patient from periphery, a 60-year-old with stage 1 endometrial cancer without lymph node removal, so what would you do in that scenario? Dr. Sunandan, please.
Sir, it's a difficult situation generally. But what I would prefer is, if it is grade 1, I can suggest for observation. Otherwise, I will go for complete staging surgery.
Observation or complete staging?
Yeah, observation only if it is grade 1. And it is the 1A, right?
Yeah, so that is what we want you to qualify, whether it is 1A or B.
Yeah. So
That is what
if it is 1A and grade 1, we have the option of observation also. Otherwise, staging surgery should be offered.
Dr. Rupinder.
So when we often get such patients, so the first thing we ask of them is to get a slide and block review done at our place. And from that, we hope to know what is the grade of the tumor, what is the LVSI, what is the myometrial invasion, if at all there is. And then depending on all these factors, then only we take a call if the patient needs lymph node dissection or not. So because if it is a stage 1A, grade 1, there is no LVSI, there's no myometrial invasion, the low uterine segment is free, there's no cervical involvement also, we can put the patient under observation. However, if any one or any two factors are positive, then perhaps we would like to do formal staging.
So Dr. Kannan, patient has come, patient is grade 1B, and there is LVSI, and the patient does not want any surgery.
Again, going back to the POTEC trial, they were just now, Dr. Bon Shetty gave an answer that, in fact, in Netherlands, about 50% of the 40% of the people did not have a lymph node dissection at all. Probably in stage 1 and 2, it is accepted. So there is not a necessity if it is a stage 1 and if it is a low risk factors. And if the patient is going to have a problems like based upon, we classify low risk, intermediate or intermediate, high risk or high risk, depending on that, either a vaginal, like we discussed earlier, or an external artery.
So it can be a substitute for surgery if the patient.
No, we don't say, no, we don't say it is a substitute.
So if the patient is not willing for surgery, then what to do?
No, it is one of the accepted surgery. What I am telling is only BSO, that is salpingoprectomy, hysterectomy, salpingoprectomy is one of the accepted surgery for a low risk endometrial cancer.
No, but here, if the patient is got myometrial invasion and patient has high grade tumor and LBSI, so then patient doesn't want any surgery, then radiation has to be done.
Radiation has to be done. There is no question about it. I am not telling that again putting up for a surgery. It depends upon the institution's practice. That's what I told you. POTEC 3's data. 40% of the patient did not have a pelvic lymph nodal removal.
Okay. So I think let's move on to the last part of the discussion. Next, please. So that was on molecular. I think I'll skip these slides in the surgical staging. Next. So I think we have partly covered molecular testing. So Dr. Jaya, you already, I think you're there still?
Yeah, I'm there still, yeah.
So can you shed some light on the molecular testing? Next slide, please.
So what we generally do is, because we know that, there are 4 subgroups, which is like P53 mutated, poly and MMR deficient, and of course, which none of these subtypes. So what is easy, we are not doing poly right now, and that is still being validated because that needs to be done by NGS. However, the other 2, like the MMR proteins and the P53, that can easily be done by immunohistochemistry, and now more and more we are doing that routinely for our endometrial cancers. And in addition, although not a part of the risk classification, we also do the ERPR on these patients, although that is something that we do. So I think, and where it helps of course, presently our treatment is not based on these P53 or the MMR deficient. But if you look at, I think that is something that we look at in future, like colon cancer, because if you see in the recent molecular analysis by the POTEC 3, the MMR deficient subtype or the polymutant, of course, did not benefit any, but in the MMR deficient subtype, if you see the chemotherapy, if anything, is worse. Of course, there is no significant difference, but if you see the outer bound of the hazard ratio, it's almost 2. So definitely there is, maybe in future, of course, not today, but maybe in future we might say that, okay, MMR deficient stage 3 does not need chemo, and a P53 mutated stage 1 needs chemo. But that is, of course, not how we treat today. We would, as we mentioned, just go by the stage and the subtype.
So I think can you have the next slide? Which shows you a potential, stage 1 endometrial carcinoma, which is high intermediate risk based on the POL and the MMR. The intermediate and unfavorable one can decide the type of radiation to be given. So, this possibly is futuristic. Jaya, you agree?
Yes, that's a futuristic thing. And of course, we need for more validated data and of course the POTEC 4A trial. So all these, I think we await these trial results.
So anybody, Dr.
Yes.
Rupinder wants to make a comment? Yeah, Dr. Kanan.
I just want a clarification from Dr. Jaya. Any Indian data on the molecular integrated risk profile and the survival we have?
Really, I will need to check that, sir. I've not.
Okay. Thank you.
Yeah.
Thank you.
Dr. Rupinder, are you doing those kind of studies at Rajiv Gandhi?
We are actually, like I said, we are doing P53 for and ERPR for all, and we are doing some amount of NGS for a few difficult cases, but really not for everyone. And of course, MMRD also we are doing. But then again, not all cases, because these things are expensive. So we do explain to the patient that this is going to cost you that much bit extra. Because for all histologies, we are doing an IHC as it is. So that IHC and various, whether it's P53 or P16 or if it is something different, we do resort to that. So if we add all these tests, unless we have a standardized pattern and the cost factor has been, cost has been factored in, I think it will take us some time before this becomes a regular
I think it'll be interesting
for us.
Look at these parameters in our society or in our community as to what percentage of patients are, P53 positive and MMR positive or Pol E positive. So those are the studies which we should do. So your final comments, Dr. Jaya, on the histology which warrants chemo and the number of cycles, serous and clear cell and all. Yeah.
Okay, so stage 1, serous carcinoma, stage 1 and 2, serous carcinoma chemotherapy. Stage 3, all cancers, all subtypes chemotherapy. So that's my take. And we give 4 cycles of paclitaxel carboplatin and followed by CTRT. And when we give CTRT, we usually give the weekly one, although the POTEC 3 has used the 3 weekly cisplatin.
Okay.
Again, a clarification.
Yes, sir.
Dr. Jaya, stage 1 without invasion, no chemo?
Sorry, sir. Stage
1, no invasion. No invasion. Serous carcinoma, no invasion. No chemo?
That's a gray area, sir. So it is because if it is a stage 1 serous without LVSI and it's just a polyp which is a serous,
yes,
then it is a difficult call to take, and many a times we just give them only RT because that is of course a gray area and really not, we don't know which ones do benefit or not.
Okay.
So there's a question which I raised from Yamini Kansal. Will the benefit of RT be still there if 2 months have passed after surgery by the time chemotherapy finishes? Dr. Kanan?
Nothing more. I don't get you.
No, the question is that since the radiation is being delayed while chemo is being given, so will the radiation be effective after 2 to 3 months of surgery?
Yes, we have been practicing that. We do chemo first and then only followed by radiation therapy. We have not per se found out any major drawback in that.
Okay.
There is no, I cannot say the data is available in that way. We follow that.
Okay. So I think we've covered a fair amount of questions, cases, issues on early stage uterine cancer. I'm thankful to all the panelists who have really contributed to each and every point which we raised here. Gautam, you have any questions, you can always ask. If there is anybody else who wants to ask, the panelists are still available at 9 p.m., which is running a little late for these webinars. So I think we come to a close of this wonderful session on endometrial cancer. Thank you very much, Gautam, for the invite.
Thanks, Dr. Shyam.
Thank you, sir. Thank you very much.
Thank you. Thank you. Thank you very much.
We also agree to disagree. Thanks.
Yes, thank you.
Thank you so much.
Yeah, thank you.
Thank you all panelists.
Smiling,
Thank you all panelists and Dr. Shyam sir, and for a nice and fruitful discussion. So we are reaching the great academic fest over the 2 days. And finally, I would like to invite Dr. Gautam to give his concluding remark for this. Thank you.
Thanks, Dr. Chandan. So that comes to the end of the 2 days of wonderful discussions as well as teaching. I thank all the panelists participants, other colleagues who have joined us, and the backdrop organizing team for such a wonderful session. So I also thank our pharma colleagues who have always been have helping hand and try to share their inputs so that we can organize such meetings. I like to thank Intas, Cipla, AstraZeneca, Fresenius Kabi, Dr. Reddy's, Lupin and Glenmark for helping us in organizing such meetings.
5 minutes.
So I thanks all of you and invite you for the dinner. Thank you, everyone.
Thank you. Thank you so much.
Thank you, ma'am. Thank you.
Thank you, Dr. Gautam. Thank you, Dr. Chandan, and thank you, Dr. Sampada, for being such a wonderful host. So have a wonderful evening to all of you from Horizon Conference Management. See you soon in some other platform. Sir, with your permission, can we leave now? Can we stop the meeting?
Yes.
Okay. Okay. Thank you. Thank you so very much. Thank you so very much.